Yes, ma'am, please go ahead.
5 minutes, huh? Narendra sir is joining in 5 minutes.
Good afternoon, everyone. Namaste. It gives me immense pleasure to welcome you all to the third and concluding day of the FOXY ICOG online certification course on genetics and fetal medicine. So after 2 power-packed days of insightful learning, we now step into the day 3 with renewed energy, regaining our wisdom from another lineup of exceptional speakers. And before we go further, we need some words of wisdom from Dr. Sadhna Gupta, madam. Madam is the ICOG Vice Chairperson elect, the co-chair CEFOG NCD committee, FOXY representative to CEFOG. Madam has got multiple individual awards and honors for her community work. We all have been knowing Dr. Sadhna Gupta, madam, for over 2 decades as a very active FOXian and conducting a lot of wonderful academic programs, as you all can read on this slide here. Madam, could we have blessings and words of wisdom from you, please?
Thank you, Dr. Pooja. And it's a great pleasure to welcome everyone on the board for this very, very needed and very, interesting, the time of the, that is the need of the time that we have to be updated on the genetics and the fetal medicine. What is the relation? My sincere regards to FOXY President, Dr. Sunita, ICOG Chairperson, Dr. Parag Viniwale, Vice Chair, Dr. Ashok, and Dr. Sarita Bhalerao, Secretary, ICOG. Dr. Pooja Lodha has been known for her deep interest and the very teaching capability, what we see her passion in the fetal medicine, and she is spreading knowledge since years. What we can say, we have been knowing her dedication to the field of fetal medicine, and we welcome Dr. Sita Ramurthy Pal, Dr. Chinmay Rata, and Dr. Pooja Lodha. So both have been the pioneers in the fetal medicine, and Dr. Kanan Kodwala, Dr. Nayana, and Dr. Aarti as a coordinator. So this is the issue in the genetics that with the Human Genome Project, we have come to know a lot of understanding how diseases are originating, how as an obstetrician we can intervene. But for a common obstetrician and gynecologist and all over the country, and we can say all over the world, actually the average clinician is lost totally, because genetics is something alien language of God. We are not able to understand fully what the genetics says about it. So with the very highly experienced and capable faculties, Dr. Narendra Malhotra, Dr. Seema Thakur, Dr. Veronica, Dr. Shilata Nair, Dr. Meenal Agrawal, and Dr. Manjeet Mehta, and with the chairpersons who will be giving their pulse of wisdom, I think everybody who will be going through this 3-day certificate course on the genetics and fetal medicine will be more clear that how we can give advantage of knowledge of genetics to our patient, how we can pick up which patient, which couple need these testing, how we can interpret, and how we can coordinate with the fetal medicine specialist, with the tertiary care, and how we can intervene. So this is something important thing to know about genetics, and as an obstetrician, we are intervening in the next generation future health. So our knowledge and update in skill, and the most important, that coordination between different faculties and specialties is going to benefit our patient. So I welcome on the board all the faculties, all the speakers, chairpersons, office bearers, and gratitude to all people who give their time to join these program, and actually your presence make it all the efforts worthwhile, which we all office bearers put into planning and the crafting these scientific program. So happy learning, happy enjoyable learning. Thank you.
Thank you so much, Sadhna ma'am. Your words of encouragement really mean a lot. May I now request our ICOG secretary, Dr. Sarita Bhalerao ma'am. Madam is like a pillar of strength. We just have to WhatsApp her our problem and she's back with the solution within like minutes. I'm sure Chinmay ma'am and Sita madam will agree to that. Madam is a consultant obstetrician.
I think Pooja, you don't need to. We have a very interesting program.
Okay, ma'am,
So
yes.
yeah, And I'd really like to thank everybody. I'd like to start by thanking Dr. Sunita Tandulwarkar, President Foxy, for her tremendous support. Dr. Suvarna Khadilkar, our Secretary General, Dr. Parag Biniwale, Chairperson ICOG, and our other office bearers of ICOG. A big thank you to Dr. Sita Pal and conveners Dr. Chinmay Ratha and Dr. Pooja Lodha. They've brought out this fantastic scientific program with a record number of registrations this time. You know, we do the certificate course every month, but we've had an overwhelming response this time, and it's really very commendable. So the topics are beautifully selected, and the speakers are really stalwarts in their field. I take this opportunity to invite all of you for the Part 3 MRCOG training course that we're doing for the first time, where Foxy ICOG is collaborating with the Royal College of Obstetricians and Gynecologists. It's going to be held in Chennai and in Mumbai in the first week of April. Registrations for Chennai are closed, but registrations for Mumbai are still open. So for all of you who are interested, please log on to icogonline.org, and we look forward to your active participation in this course. With that, I thank Pooja for inviting me here, and you please do go ahead with the webinar. Thank you.
Thank you so much, madam. We have with us today Professor Suvarna Khadilkar, madam, who's the Secretary General Foxy. Madam, could we have a few inspiring words from you?
Okay, yeah, I got unmuted. Good afternoon, everyone. And at the outset, I really congratulate all of you. I could not join on day one, but I have seen all 3 days program, and it has been wonderfully, curated, and it is going to be of tremendous help to all attendees. And as Sarita said, this time you have got overwhelming response, no doubt, because the scientific program speaks volumes about this course. And we, as general gynecologists, have very, limited knowledge in genetics, and in fetal medicine also is a rather narrow field to work in. And I'm so happy that you have gathered all who in the specialized field, like basically all three of you, Dr. Pooja, Dr. Sita, and Dr. Chinmay. All of you are yourself great asset to this certificate course. And today's particular session, I see Dr. Narendra Malhotra, who has been very, knowledgeable and stalwart in this field. He is going to speak on genetics in infertility. Dr. Seema Thakur on genetics in RPL. I think a lot of important topics are being discussed. Dr. Veronica, Dr. Sri Lata Nair, Dr. Meenal Agarwal, and Dr. Manjit Mehta. And it has been a team effort and a huge program. I wish you all the best, and I hope all the attendees are benefited with this particular program. And I particularly thank the entire ICOG team, ICOG Chair, Dr. Parag Biniwale, Dr. Sarita Bhalerav, and entire organizing team. And I want that, more and more such certificate programs are organized so that people will get more confidence in their clinical practice. Thank you so much.
Thank you.
Thank
so
you,
much.
madam.
Thank you. I
Team
just want
is
to chip in to thank Dr. Sarita and Dr. Suvarna Khadilkar. Sarita, I've been after her. Please give me a time, a date, and a month. So thank you so much for this, giving us this opportunity. And thank you, Suvarna, madam, for joining in. I'll be the last day, but it is really very kind of you to give those encouraging words. Thank you so much.
Thank you. Bye-bye.
Sita ma'am. So a team is a reflection of its leader, and we have with us, always supporting us, Dr. Parag Biniwale sir, the chairperson ICOG. Sir, quick words of inspiration from you, please.
Just 1 minute, not words of inspiration, but just wanted to appreciate and thank the three of you, Sita, Chinmay, and Pooja, for putting up such an interesting program, and the attendance speaks for itself. Of course, the quality of presentations is excellent, and you handpicked all the who's who in the field of genetics and fetal medicine. So I appreciate your sincerity and your commitment to Foxy ICOG. Keep on supporting all activities of Foxy ICOG. Thank you. Let's begin. It's 4:10.
Supporting us always. Thank you.
Thank you, sir. So at the outset, officially, I would like to thank President Foxy, Dr. Sunita Tandurwarkar, Madam, Chairperson ICOG, Dr. Parag Biniwale, Sir, Vice Chairperson ICOG, Professor Ashok Kumar, Secretary General Foxy, Dr. Suvarna Khadilkar, Secretary ICOG, Dr. Sarita Bhalerao, and my special thanks to my mentors and co-conveners, Dr. Sita Pal and Dr. Chinmay Ratha, for guiding through this beautiful crafted topics for today. Our young fetal medicine brigade today is Dr. Kanan Kotadwala, Dr. Navya Casey, and Dr. Aarti Yevle, the 3 coordinators for the 3 days of the online certification course. Friends, the future of medicine is being redesigned by the language of genetics. And in the double helix lies not just our past, but the promise of the future. Today, we are fortunate to be in the company of some finest minds in academia, and we are privileged to have their guidance as we navigate through some of the most cutting-edge, relevant topics in gynecological genetics. Genetics is no longer just the frontier of the future. It has percolated almost in every branch of medicine and in gynecology alike. So today we have a very promising lineup of topics, and genetics in infertility, genetics in RPL, approach into a case of primary amenorrhea, inherited cancers, genetics in DSD, and PGT. We often have been listening to genetics for cancer and prenatal genetics, but something new is this third day where I think even we conveners, coordinators, and the faculties would be learning a lot from each other, because this is a relatively new parallel branch of genetics, which is gynecological genetics. So without further ado, let's begin this exciting academic journey. And may I please have the slide of Dr. Aarti Yevle, who's my coordinator for day 3 today, who's helped a lot in coordinating with all the faculties and fetching MCQs. So Aarti is a young budding fetal medicine specialist, and she's from Pune. She's a consultant fetal medicine at Noble Hospital and Adarsh Nursing Home, Pune, and she's done her fellowship in obstetric ultrasound and ICOG training in fetal medicine from Hyderabad under Dr. Chinmay, Madam. So Aarti, over to you to conduct the academic sessions now.
Thank you so much, ma'am. So like Pooja ma'am has already mentioned that genetics is ever evolving, and today is going to be a topic and this a whole program where everyone is going to learn a lot. So let's get started with the first session, for which I would like to invite our chairpersons, Vasundhara Tyagarajan madam. Ma'am is a senior consultant or obstetrician gynecologist, sonologist, and laparoscopic surgeon from Chennai. She is the director of BM Hospital, New Life Fertility and IVF Center. Welcome, ma'am. Our second chairperson is Dr. Fessy Lewis, sir. Sir is senior consultant, associate professor in charge for the MCH course, Department of Reproductive Medicine and Surgery at Amrita Institute of Medical Sciences, Kerala. So welcome, and thank you so much for being here with us. I would request Fessy Lewis, sir, to invite and introduce Dr. Narendra Malhotra, sir, our first speaker for today.
Good evening to all. First of all, let me thank the ICOG for giving this opportunity, and Dr. Sida for this wonderful initiative, and also the coordinators Pooja and Dr. Ardi. And without wasting time, we'll go to the first speaker. It is none other than Professor Narendra Malhotra, sir. As you all know, sir is the Managing Director of Global Rainbow Healthcare Hospital, Director of ART Rainbow, Director Foxy Smriti Manada CSE, and Vice President Society for Ovarian Rejuvenation. And sir is the Director of the Project Positive Health Rotary District 3110, National Director of Jan Renault School of Ultrasound, Professor of the college in Croatia, Professor of Indian Medical Association. And I think it will take half an hour to read Sir's CV. But Sir doesn't need introduction. Sir is a wonderful teacher and a guide and mentor for most of us in Foxy and ICOG. Over to you, sir, for genetics and infertility, sir.
Just a second, I'll just get my slides set. Very good afternoon to all of you. It's indeed a pleasure to be associated with the ICOG training programs and talk to all the youngsters and also the seniors on something what is taking over as the future of medicine, and that is what we call as genetics. So I'm going to take you through in this 20, 30, 20, 25 minutes on the genetics of human reproduction and fertility. When we talk about infertility, we all know that 1 in 15 Indian couples struggle with infertility. 50% of them have underlying genetic causes. It's that bad. And both female and male factors account for about 1/3 of infertility in each because of that. 50% of them are in the embryos from IVF, which will have some chromosomal anomalies. And 40% of normally looking morphologically embryos also have aneuploidies. So that is the problem of genetics. And before we go into specifics, let's understand a few terms and some tests, and then we'll go into the specifics. So we need to understand a few basics of genetics. Infertility has gone beyond hormones to genetics. Couple experiencing infertility can often now be associated with chromosomal anomalies, which can occur both in male and female. That could be deletions, chromosome missings, inversions, upside down, mutations, gene sequencing, aneuploidies. And these are the terms which we'll like to explain to you first. All these in male are manifest as Klinefelters, translocations, Y chromosome microdeletion, X chromosome defects, CFTR gene mutation, 13, 18, 21 trisomies, epigenetics playing a major role. And in the female, Turner's, translocations, hypogonadism, premature ovarian insufficiency, trisomies, genetics of endometriosis, genetics of PCOS, and of course, epigenetics. So let's understand what is human genome. Human genome is the gene is the basic unit of inheritance. The genes are organized on chromosomes. We have 23 pairs of chromosomes at 46 total. 22 are autosomes and 1 is sex chromosome. Human genome consists of 6 million base pairs. We'll come to this. And 20,000 genes encoded proteins, exons, which are 1.5%. The rest of them are regulatory genes, which are about 8%. And all the rest is junk. So we are full of junk in our chromosomes. Chromosome has 2 chromatids, as you can see here. And these chromatids are the short and the long arms. They can be in the center, which is metacentric. It can be subcentric. It can be acrocentric, as you can see in the third picture. And these 2 chromatids, the short arm is the P arm and the long arm is the Q arm. Then what we look like is our phenotypes or the experience or the physical experience, yours and mine. What is inside us is our genotype. That is our blueprint. What is inside our blueprint is a karyotype, which is our chromosomes. What is inside this chromosomes is the genes, 30,000 plus genes. Each gene has an allele, that is 2 alleles, gene alleles or gene locus. Now, these alleles can be homogeneous, homozygous, similar, or heterozygous, different. And this is how the genes or the genetic comes to us. 23 come from the father, 23 from the mother, making us as a 46 chromosome person, 1 6K pair. And this is how normal karyotype, each chromosome has different shape. So they're picked up and paired, and then you get a report like this, which is a classical chromosome karyotype, or what we call as a karyogram. Now, the DNA is inside the chromosome, which is known as a deoxyribonucleic acid. And it is located in the nucleus. It is wrapped up in the structure, which is called chromosome. When you open the chromosome, it is a double helical thing which opens. And this double helical is joined to each other by base pairs. And these base pairs, 1 million of them, are A, T, G, C. So nucleotides, adenine, thymine, guanine, cytosine. And they form the double helix structure, and they're in a correct sequence. So if something is wrong or missing, you have the nucleotide defects. That is how we remember. So a part of this DNA codes for the proteins, and a lot of this DNA is a junk DNA. The part which codes for the proteins is exons, and the intron part is the junk one. That is, when you straighten it up, you see it appears like this. The introns in gray and the exons in the greenish. So exons are the coating part of the DNA, or the working part. And the junk part of DNA is the introns. And we all know that 1.5% and 8%, and the rest is all junk. Now, what abnormalities can happen? The abnormalities can happen in the DNA itself, at the chromosome level or at the single gene level. So single gene level, trinucleotide repetition, that means the ATCGA is repeated, or it is deleted, or it is inserted, or there is a point mutation, or there is a chromosomal level, there could be aneuploidies or translocations. And we need to understand this. So if you have abnormal number of chromosomes, it is manifests as Downs, Edwards, Patayu. If it's live born, abnormal structure of chromosome, Chiari-Short, DeGeorge and Williams, sex chromosome abnormalities, Turner's and Klinefelters, single gene mutations like cystic fibrosis, thalassemias, and G6PD. So if the number is missing, it is aneuploidies or one extra, which could be missing, or monosomy, could be trisomy, or could be tetrasomy, 4. Or it could be polyploidy, which is triploidy or tetraploidy. That means all the chromosomes are 3 or all the chromosomes are 4 instead of 2. So these are the numerical defects. And this can lead to Downs. This can lead to trisomy 18. 18 is 3. This can lead to Patau, which is trisomy 13. And there is an extra chromosome at 13. We have to understand this. Or it could be in the gonosomes. That means the X and Y. There could be 2XY. That means double XXY, which is Klinefelters. And there could be a missing X or a Y, which is XO, which is the Turner syndrome. Now, these are the ones which are live born. Hence, we're talking only of these. The structural abnormality which can be occur is in the structure of the chromosome, which could be a part would be deleted, part could be duplicated, part could be inverted, part from this side is inserted in the other, part from this side is translocated to the other, up, down, anywhere, and translocated. So these type of chromosomal structural abnormalities can occur. The translocation, a segment from one goes to a non-homologous chromosome or to a new site in the same chromosome. This is translocation. And this could be balanced or unbalanced. And so that's what we call as the Robertsonian translocations. Now, genes may be inherited from the parent. Now, if you have a dominant allele, you see that a phenotype. You have a recessive allele, it is a carrier. You have incomplete dominance, that means some part of the gene is dominant, that like curly hairs, blue eyes, and your structures of that single part. You have a co-dominant, that is the blood group and sickle cell disease. You have multiple alleles, like in ABO group and hair colors. You have polygenic traits, that is your skin color, and you have multiple genes related to skin type, eye color, hair color. So these are inherited, and they are inherited from the parents as a dominant or a recessive. Now, how do we test it? We can get a sample from the blood, from the chorion villus, from amniocytes, from organs, tissues, cell lines, forensic semen, hair, skin, under the nails, cases of murder and rape. Histology sections, you did a hysterectomy, that slide is stored. You can get genetics of that. Single cells, like from blastomeres, on doing a implantation genetic diagnosis, or from buccal cell of the skin. Why is it this important? Because 20% of birth defects are there. So we need an accurate diagnosis. What is the genetic basis of female and male infertility? Because of this mutation, various diseases can occur, and this may cause male or female infertility. Infertility affecting about 50 million couples. I think it's 80 now, and the prevalence is rising. 25 to 30% of them would have a genetic etiology, and if done well, maybe up to 50%. So we need to apply the next generation sequencing, which gives us the decoded genome and gives us an idea what this person's genome is and whether they're going to be infertile or not, we can predict. And these diseases could be because of cytogenetic abnormalities, that means the whole chromosome, because of single gene defects, and because of the epigenetic aberrations. Epigenetic plays a major role. Now, this can happen during the cell division. So cell division we know is mitosis and meiosis, and the XX homologous pair synapses creates 2X, and that is how you get this. So that it can be, might happen anywhere here. So cell double checks the duplicated chromosome and the error. It repairs most of the times. If it is not repaired, then it leads to a abnormal spermatocyte or an abnormal oogenesis, oocyte. So spermatogenesis and oogenesis, while the division occurs as mitosis 1 and meiosis 1 and meiosis 2, can have a chromosomal abrasion anywhere at that time. And this will lead to abnormal sperms and oocytes right from birth or at puberty or later on in life because of the bad epigenetics, and cause problems. So what are the tests we can do? We can do some diagnostic tests. We can do some predictive tests to detect gene mutation. We can identify carriers, whether your family has a recessive genetic disorder which is being carried from generations and will go on to the generations. You can do prenatal testing, that is after pregnancy occurs. You can do screening of the newborn when the baby is born. Of course, forensic testing for murders, rapes, and things like that, legal purposes, and in research setting. So these are the where the genetic tests are applied. Now, what are they applied? You can do a chromosomal analysis or karyotype. You can do the abortus material genetic testing. We can do beta thalassemia mutation. We can do torch testing by genetic PCRs, Duchenne muscular dystrophy, bad obstetric history panel, recurrent abortion panel, and infertility panel. And these would give us an idea of so many diseases which can be transmitted, like Wilson's, cystic fibrosis, beta thalassemia, sickle cell, cardiomyopathies, non-syndromic hearing loss, hereditary hemochromatosis, retinitis pigmentosa, Wilms tumor, epilepsy, hemophagocytic thing. So if these diseases are there, then it is very good idea to test complete genome. So what test to do? Well, you can do karyotype, FISH, PCR, PCR with microarray, and next generation sequencing. So one slide of each. You will do chromosome study, it will give you low sensitivity, tells you the numbers. You do a FISH, which is colored sequencing, and that can give you signal artifacts. So you can get a signal different color and of course we do a target specific PCR. So karyotype report will come like that. FISH report will come like dots of colors on whichever gene chromosome you're testing. PCR will sequence or multiply that genetic material and sequence it. So you need live cells, cannot be done on an abortus. The next generation sequencing is on the chips. You can sequence, and the microarray can be done on dead cells. So the abortus material should be tested with microarray. Let's see what they are. Number one, the chromosomal analysis. Chromosomal analysis from the blood, you do a karyotype. They get into the slide, all of the are mixed, and you stain them and pick them up and fix them, and you get a karyotype. And that karyotype will tell you the number changes and structural changes. So it will pick up normal, it will pick up aneuploidies, it will pick up sex chromosome anomalies like Turner's Klinefelters, and it will pick up balanced reciprocate translocations or deletion macro or micro. So karyotype will pick up all this. In the female and the male, it will pick up Turner's POF or translocations and deletions. And in the numerical also, you might get XYY or XXY super females, and also it will pick up Robertsonian translocation, inversions and deletions. That is what the chromosome will pick up. And the report will be given something like this, which you see the picture now. For XY, clinical features are there, and then you get it done. And these patients will have infertility, they will have cardiac defects, they will have pigmented nevi, and the other diseases which are there. Similarly, the monosomies, mosaics, all that can be picked up by a karyotype. The Klinefelters will show XXY, and this man is infertile, has a high FSH, elevated LH, sperm counts are very low. They can father children, but probably they will need ICSI to do that. And when you do ICSI, it may be trans. It can also pick up mosaics. That means they're mixed. It can also pick up Y chromosome Q deletion. That means a long arm, and Y inversion deletions. In the females, deletion XP. deletion XQ, that is a long arm, and inversion of XQ, that means a long arm is inverted. So the mosaics of Klinefelters and Turners will also be picked up, and they all land up into infertility. The second test is the FISH, fluorescent in situ hybridization. These you have to put the color, and according to the color you put, you get the colors. So usually we do it only for 5 chromosomes, now only for 3, 13, 18, 21, and it will tell you all this. The third is a PCR sequencing. You're taking a DNA material and you're amplifying into millions of copies in the machines, and then you are analyzing it as a high resolution. So PCR sequencing can be done. PCR microarray can be done from the dead tissue and also from the blood and also from any other tissue, and gives you much more better resolution of what you're looking at. Then, of course, you have the whole genome sequencing, and the whole genome sequencing or PCR will be like that. Specifically focusing in infertile male, we will look for Y chromosome microdeletions. Now, you know that the Y chromosome has a centromere, the short arm and the long arm. The long arm has AZFA, AZFB, and AZFC. And there could be a YQ11, that means that part is gone. It could be an overlap, it could be inversion, and all these problems will be seen in men who have a semen analysis of less than 5 million. You'll see YQ11 named azoospermia. You'll see the AZF absent. 3 reasons could be deleted and lead to azoospermia. And when you do a testicular biopsy on these men, it will show germinal cell maturation arrest or Sertoli cell only syndrome. So you test the Y chromosome only if the semen analysis is less than 5 million. And there could be a lot of deletions. So areas of AGF, A, B, C could be deleted and leading to male infertility. And this is the STS, what we call as AZF microdeletion, are picked up by specific tagged sequencing. And you can get the report as multiplex 1, 2, 3, and that'll tell you the whether the deletion is there, which will be seen in 7% of azoospermics and 4% of severe oligozoospermics, as according to H. Then 98% of cystic fibrosis male are infertile because of the congenital absence of vas difference. So the mutation of CFTR gene on the chromosome 7q3, Q is long arm, point 1 and 2, that is the area of that. And this will affect about 1 in 2,500 newborns. And they may be just carriers and seen in Caucasians. CFTR present with obstructive azoospermia without manifestation of cystic fibrosis. So the testis is normal and you may get testicular sperms. And these patients can get their pregnancy on T-Psych. The last method to do is next generation sequencing. Now, this is Sanger started this sequencing, and you see the sequence of AGTC, the nucleotides, which are 1 billion pair. And these are done in machines. They're done automatically, and they'll give you a sequencing by the machine. So the next generation sequencing is a faster and a quicker method. It takes only 5 to 6 hours. Some takes 1 to 2 days, and the other high series. The analysis of the data is based on the computer. Many samples can be tested together. So the cost is going to become cheaper and cheaper. And the strategy will be that now we will be able to do whole genome sequencing at a 1000 GB sequencing, high resolution. Whole exome sequencing, where we can capture all the 20,000 exons and sequence them and sequence and analyze them. We can do target sequencing, so we can sequence only the part or the where we are interested in. And of course, we can do the transcriptome sequencing, or what we call as the RNA sequencing. The cost is falling down. And now it is going to be very, very affordable as soon as we have. We also now have a low-pass genome sequencing, which I just heard about it from one of the labs. And this low-pass whole genome sequencing can be applied where you need a traditional whole genome sequencing. Because with this, you will probably get a faster and a better value because it's technology. And the report will be something like this, which will tell you exactly where things are going wrong. What it can do is comprehensive coverage, detects events, flexible, identifies rare events. NGS holds immense potential transformation and advancement. And with technology, the cost reduction is there. What it cannot do is pick up the balanced chromosome rearrangements. Karyotype is required there. Heterozygosity, uniparental disomy coming from only one parent, single gene disorders and point mutation, and low level mucus. So we have to know that each test has its limitations. So why, if everything was working well, why are we changing into this? Well, we are changing because technology is evolving. So to recapitulate, male infertility will be 46XXY, 45X, 46XY mosaic, structural abnormalities, inversion of the Y, sperm, fish, and Y and X probe in low count, CFTR gene for cystic fibrosis in congenital absence of VAS, and Y chromosome may show 20 types of deletion. So these are the genetics of male infertility. In the female, on the X chromosome, DIA gene, XQ, FMRI gene, cyst locus, that is X locus, X in site, and the other rare disorders can be seen, especially when there is a premature ovarian insufficiency or premature ovarian failure, where there is a X fragile. So your fragile X syndrome is affected. Then also in PCOS, PCOS now we all know has a genetic basis, and we can study the genes of PCOS which are involved in steroidogenesis and not in ovulation. And also you can put the jigsaw puzzle together to diagnose and prevent diseases like juvenile arthritis and the other disease. And we can apply this in cases of all bad obstetric history, which is 24% genetic, to get the whole panel of infertility, which is there by almost all of them. One of such panels, as you see, is here, which gives you karyotype, chromosomal microarray, couple carrier genetic testing, single gene mutation testing, molecular analysis of the male, sperm analysis of the male, genetic profile of the male, and genetic profile of the female. So all these tests are available and now affordable and can be done by either microscope karyotype, CMA, exome sequencing, PCR sequencing, fish, exome studies from blood or from semen or whatever. Where else is required genetics is for the prediction of implantation. So endometrial receptivity, you require genetic study of the endometrium, standard window of implantation and delayed window of implantation, and advanced window of implantation can be studied by doing an endometrial sampling and a gene study for endometrial receptibility. Where else is required is that we can do an endometrial microbiome studies. So importance of lactobacilli in the endometrium and endometrial microbiome, and the whole comprehensive test comes as endometrial receptivity, endometrial microbiome testing. It is still expensive, but it is a very good predictor for endometrial embryo transfer, optimal time for embryo transfer in IVF cases. So these panels are all available by various companies which are there. So different aspects of infertility which carry are hormones, genetic screening carrier, genetic screening for male and female with POF, PCOS, endometriosis, oligospermia, asthenozoospermia, and for azoospermia, cytogenetic studies that we've just shown you, and pre-implantation genetic diagnosis. So where we can take out one single cell and study it and give you one. When we know that so much things done, why is it still uncommon? Well, until recently, we thought that there was no test. Until recently, we thought it is very complex and very overwhelming. Until recently, it was very expensive. And the results are very difficult to interpret. The relevance of the result may be ambiguous, so we don't know what to do. And often, if we find the result, still there is no change of the treatment. Now, this has all changed. So your attitude towards genetic testing has changed and needs to change. I have been practicing for several years. Why genetics now? We both were very interested in long back since we were getting the buccal smears done and things like that. Now it is the time where genetics plays a very, very important role in this. So infertility has gone beyond hormones to genetics, and we need to study all the genetics. And we have to take these tests whenever there is POI, aromatase excess, placental aromatase deficiency, PCOS, galactosemia, ovarian hyperstimulation, hypogonadistic anosmia, precocious puberty, LH resistance, pseudo-hypoparathyroidism, oocyte maturation defects, adrenocortical insufficiency, adrenal hyperplasia, congenital adrenal insufficiency, thrombin deficiency, thrombophilias, antithrombins, PCOS, calamine. So these are the disorders which can cause or we are associated in infertility where all these tests has to be done. And of course, so the carriers, all the couples need to plan. So we have to make a genetic kundli, probably. Not that we are discouraging them if something is wrong, not to get married, but at least counsel them that something can go wrong in your offspring and you need to take care. So couples with genetic risk can have carrier problems, affected child, advanced age, recurrent miscarriages, IVF failures, and genetic related diseases. And all this can be worked up now with pre-implantation genetics. So ladies and gentlemen, the take-home message, a recap is that you must know how to draw a pedigree tree. And a quick recap, the pedigree tree, these are the symbols which all of us know, should know, and a pedigree tree we should all draw for all pregnancies and all couples so that we can know at a glance what is wrong. And that is how a pedigree symbols are, which should be known to all of us by heart and should be done. A pedigree tree by male, female, unspecified sex, deceased, stillbirth, adopted into family, marriage of union, divorce, consequently, monozygote, dizygote, everything, if you draw a pedigree tree, can be at a glance known. So genetics today still is viewed as a nuisance, complex, and clinical management cannot be done. Family histories are usually inaccurate. There is limited genetic counseling available, which we all should start learning now. And the commercial labs are very expensive. So the bottom line is that today women want an informed choice. Genetic centers are welcoming inquiries and referrals. So whatever you can't understand, it's the Zooms and web calls are always there for you to talk to a genetic counselor on what test to be done. So genetics has entered the mainstream medicine. Thank you very much for inviting me here for this ICOG lecture. It is a difficult topic which I've tried to simplify. We've also put them into a lot of our books, which all of you can read. And we are always available for any questioning and any counseling which you might need or on this difficult topic. Thank you once again for inviting me for this interesting topic in an interesting training course. Thank you.
Thank you, sir. Thank you, sir, for that elaborate discussion and making it the so difficult topic very simple. Then I think, are we going to take the questions or?
No,
So
questions.
there
No,
is a
sir.
post-test,
Questions, sir.
so we will reserve the questions for the end, sir.
Yeah.
Okay. At the end,
Candidates can
all the
type
speakers
on
will
the
come at
chat
the end.
box.
Okay.
Any questions they can type on the chat box also.
Yeah.
I think Dr.
Thank you so
Vasundhara
much,
can
sir.
introduce the next speaker then.
Yes.
Yeah. Good evening, doctors. Thanks for the opportunity given to me. Genetic becomes more important for our day-to-day practice, cutting the edge research in genetics and genomics. Sessions like this give opportunity to learn from the experts like Dr. Malhotra in the field of genetics in gynecology. The next speaker, Dr. Seema Thakur, Director Medical Genetics, Fortis Hospital, Salima, Delhi. Visiting consultants, Rainbow Hospital, Delhi, and Genetic Clinic, Delhi. She is Secretary DGF Dwaraka 2023-25, and her special clinic RPL preconception and hereditary cancer. So today's topic is going to be apt for her specialty. And on her side, publications more than 71, and she has got the Distinguished Medical Luminary Award from the IME Women Doctors Association. Over to you, Dr. Seema.
Thank you, ma'am, for such a kind introduction.
Thank you.
Is my screen visible?
Yes,
Can you
Yes, we can
but
see
make
the
it,
screen.
yes,
Yeah.
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 Yes. So at the outset, I would like to thank organizers for giving me this opportunity. This recurrent pregnancy loss is one of the common problems in the women, those who come to us. And in this talk, I would like to discuss about both the genetic and the non-genetic causes, and few important areas where we get the genetic referrals in cases of the RPL, that is the balanced translocation carrier. We get lots of couple with the 9QH plus. We get women with trisomy X, and indications for microarray. Started thinking of whole exome sequencing, and the commonest question surrounds us is the how to transport the POC. So I'll be, discussing keeping my discussions around this only. So as you all know that miscarriages, there are two types of miscarriages, the sporadic and the recurrent. So the sporadic is generally because of the fetal problem, and majority of the time they are random. And this increases with the maternal age. So when the women are young, the incidence will be around 10%. And when they are older, like at 45 years, the incidence may go higher up to the 50 years. In contrast, 50%. So in contrast, the recurrent miscarriages are traditionally defined as the 3 or more miscarriages, and they affect 1 to 2% of the women. And the risk factors we all know is advanced maternal age, advanced paternal age. The more the number of the previous miscarriages, then the consanguinity, the smoking, alcohol. Many women these days are on alcohol. The obesity is an epidemic. Our Prime Minister is requesting us to cut down the fats. So all these are the factors for the recurrent pregnancy loss. So how do we define the abortion? Any pregnancy loss before 20 weeks is spontaneous abortion. It can be unembryonic. Embryonic death is less than 10 weeks. Fetal death is 10 to 20 weeks. And any loss after 20 weeks is a stillbirth or intrauterine fetal death. And as a general rule, about 15% of all pregnancies are going to end in the spontaneous abortions, and 50% of the first trimester sporadic losses are due to the chromosomal causes. So a definition of the recurrent pregnancy loss is important, that when to start the clinical evaluation. So traditionally, as per and RCOG still says that it is 3 or more consecutive abortions before 20 weeks of the pregnancy, whereas the ISHRE, American Society of Reproductive Medicine, they say that clinical evaluation can be started after 2 or more clinically recognized pregnancy. So they don't include the biochemical pregnancies, whereas the RCOG does not define about the biochemical. They include all pregnancies, and the incidence, as we discussed, it is about 1 to 2%. So whenever we have a woman with the recurrent pregnancy loss, her first question is always there that, why did this happen? And is this going to repeat again and again? So the moment she enters your chamber, she will have these two questions, baffling her, that what should I ask? So when we have to tell them that the etiological diagnosis is important, and we can identify the etiological diagnosis in about 50% of the cases, and the success rate is still very, very high. 60 to 70% chances of the live birth after 2 to 3 abortions. And this is the which we can remember, that if there is one loss, then the chances of abortion is 20%, and if there are 2 losses, the chances of abortion is 30%, and if there are 3 losses, the chances of abortion is 40%. So still there are 60% chances that she is going to have a live birth. And the recent meta-analysis in the Lancet, that also suggests that the miscarriages in the sporadic loss is about 11%, and this increases about 10% for each additional miscarriage. So we can remember like this. The recurrent miscarriages can be genetic, can be non-genetic. It can be, the commonest is the antiphospholipid antibody syndrome, which is also the most rewarding to treat. Then the anatomical causes. So we need to evaluate by the 3D ultrasound. Then endocrine causes like diabetes. Then genetic causes, it could be the chromosomal, or even it could be the most commonly the chromosomal, but it can be even the single gene disorders which are going. But despite thorough investigation, about 30 to 50% of them are going to, unknown. So the anatomical factors, they account for about 6 to 7%, and they can be acquired or congenital abnormalities. Congenital uterine abnormalities can be arcuate, septate, unicornuate, bicornuate, and didelphys uterus, and they are seen in about 10% of the women in the control, whereas the 5% of the control and 13% of the women with RPL. Acquired abnormalities can be fibroids, polyps, Asherman syndrome, submucosal myoma. They may be associated with the increased risk of the miscarriages. These are the different types of the uterine abnormalities, the bicornuate, the different myomas, the adhesions, the polyps. So these are the antiphospholipid syndrome. There are about 15% of them, the women with the recurrent miscarriages, and there is a criteria to diagnose both the clinical and the laboratory. In the pregnancy, it should be 1 or more death more than 10 weeks, or 3 or more consecutive abortions less than 10 weeks, or 1 or more premature birth due to the severe preeclampsia or placental insufficiency. So these are the clinical criteria. And in the laboratory, we all know that it is the anticardiolipin, lupus, anticoagulant, and anti-beta-2 glycoprotein. So the strongest factor association with the recurrent pregnancy loss is with the lupus anticoagulant, followed by the anticardiolipin. And if the test is positive, then one must repeat it after 3 months or 12 weeks. So this is a case. She is a third gravida, and she consulted us at 5 weeks, and she was advised antiphospholipid antibody and ANA, and along with the karyotyping, her ANA came positive. The lupus anticoagulant was positive. Then she consulted the rheumatologist, and we advised her the heparin and the HCQS, and she finally delivered a normal healthy baby at 38 weeks by the cesarean section. The endocrine factors, the thyroid, the diabetes, the luteal phase deficiency, vitamin D deficiency, which are all the treatable causes. So now coming to the chromosomal abnormalities in the spontaneous abortions, 50% of the first trimester abortion will have chromosomal abnormalities, and the rest will be the triploidy, Turner, autosomal trisomies, and the autosomal monosomies. So we can have the chromosomal abnormality, the numerical, like Down syndrome, like Turner. So these are numerical when there is one more or one less. So these are numerical abnormalities. In the structural abnormalities, there will be the interchange of the genetic material. Like here we can see there is the interchange between the chromosome 9 and the chromosome 4. So these are called the balanced translocation carrier or the structural abnormalities of the chromosomes. So this is a case. She has 5 abortions. Some of them were just biochemical. In one of them, it was a fetal loss after the cardiac activity, but majority have been the biochemical losses only. And she has reached us because of the translocation carrier between chromosome 1 and chromosome 3. All her other investigations like anticardiolipin, lupus, the thrombophilia profile, 3D ultrasound, everything was okay. So this is the karyotype of the mother. And we can see here there is a balanced translocation between the long arm of the chromosome 3 and the long arm of the chromosome 1. So this is a very common situation these days because you see the women with abortions and the genetics testing has reached your doorstep. So there would be quite a large number of women. We can say 1 in 500 in general population, and it accounts for 5% of the couple with the recurrent pregnancy loss. So what do we tell that when a couple comes, when a lady or a partner, her partner comes with such kind of report? So then we tell them that the chances of unbalanced karyotype is about 30%. So there are 70 to 75% chances that she can also have a normal pregnancy. These women are also at a risk of child with the malformation or child with the mental handicap, and the risk varies from 0 to 30%. So how do we counsel them that whenever they come to us? So if we see them that there is a significant the fertility in the women, like in the previous case which we just discussed, then we tell them that you take a chance, and there is a quite high chances, 70%, more than 50% chances that you will have a normal pregnancy. And then we require one amniocentesis at around 16 weeks and the routine follow-up. But suppose the partner is a carrier of the balanced translocation, and there is associated oligospermia, then in these cases we suggest them to go for the IVF and followed by the PGT-SR. someone may decide for the donor sperm or donor oocyte depending upon the situation. So it is the fertility, the background fertility, which decides whether I would send them for the IVF or whether I would allow them for the spontaneous abortion. So balanced translocation carrier is not an indication of the, so he is a male with the balanced translocation carrier. And then we see that he is a balanced translocation between chromosome 7 and 21. And his wife had about 7 abortions. Then if the number of abortions are very, very high, then we must suspect that, the bal segregation is due to the interchromosomal effect. And we will get to know this by the microarray on POC. And if the microarray on the product of conception shows that these are not the chromosomes, suppose it shows trisomy 22, then we suspect that there is some interchromosomal effect, that the balanced translocation carrier is interfering with the segregation of the normal chromosomes also. And these are the people who need further assisted reproduction rather than the spontaneous, because so this clue will only be given by the genetic testing of the product of conception. Then this is a very common situation with us, that the husband's or the wife's karyotype is showing the 9QH plus. So this is a 22-year-old, para 0 plus 3, and the husband's karyotype that showed 9QH plus. And so how do we counsel? But that this is a polymorphism and unlikely to cause problem. And there are other polymorphic chromosome 1, 9, 16, 13. Okay, this was 14, 15, 21. So how do we counsel them and why this happens? Because these are the heterochromatin, and these heterochromatic regions are rich in the highly repetitive satellite DNA sequences with no coding proteins. So these polymorphism are generally regarded as harmless variants and have no functional or phenotypic effects on the polymorphic carriers. Then the another type of women, those which we see in RRPL clinic, they are the women with the sex chromosomal abnormality like XXX, variant of the Turner. So these are 3 cases of the XXX which I have collected to discuss that why the XXX is coming more to the notice, because we are all doing the NIPT all chromosomes, and there are many of them who will get that the NIPT is positive for the XXX chromosome. And then what to tell these women? That whenever they come with this report, majority of them would come to you with this, the thing that they are going to abort it. But we have to tell as a clinician that majority of them will have normal puberty, fertility. They have a small risk of the sex chromosomal abnormality. Although the report says that the less than 5% increased risk of the chromosomally abnormal, more recent figures suggest that there is a less than 1% risk for the XXX or the XXY in these women. So majority of the prenatal cases which you are coming across, they should be counseled of the positive outcome rather than asking them to go for the termination. We can see our 3 cases here. This is a gravida 4, 3 abortions, and she had a karyotype of the XXX and was referred to us that what to do. Then we discussed with her the option of amniocentesis, but she declined and she delivered a healthy male. Then the second one, she was referred to us. She again had a bad obstetric history, 1 intrauterine death, 2 spontaneous abortion. She was referred to us for the aberrant right subclavian artery. And this was the time when we were solely dependent upon the amniocentesis. NIPT had just entered the market. So we asked her to go for the amniocentesis, but seeing her profile, she declined. Then I suggested her for NIPT that showed XXX and counseled her for the XXX that majority will have normal puberty. So she did not opt for the amniocentesis. But then I asked, can you do your own karyotyping? And she was herself XXX. In the next pregnancy, the NIPT was positive for XXY, and this was again, both the children have got 46XX and 46XY correct. None of them have the Klinefelter or the XXX karyotype. This is the 3rd case where again 1 IUD and the karyotype showed XXX. And later, of course, the child developed tuberous sclerosis, but this has got nothing to do with the XXX. Tuberous sclerosis is a majority of the times this can be sporadic also. So this is a very interesting case. She had undergone IVF and she had come to us because her NIPT was positive for Turner and PGTA was already done. So I suspected there may be some wrong report And we repeated the test. This was again showing that this is positive for the Turner syndrome. Then we had no choice. We had to do the amniocentesis. And during amniocentesis, and this was her karyotype, which she showed me later, that she had 79% normal chromosomes and 21% the 45X, and which was being picked up in the NIPT. Then we did the amniocentesis, that was normal. But while doing that, we also could see that there is a mosaic pattern in the mother's QFPCR, that is about 21%. So she was a case of Turner variant with a very low line. Then this is a very interesting case again. The wife came with 2 IVF failures, one with the self husband and the other was with the donor. And she was actually referred to me because of the husband's karyotype, which was showing ring chromosome and one Turner syndrome also. And you can see almost 50-50 they were, and it was quite surprising to see with this karyotyping a normal male with, of course, oligosthenozoous teratogewspermia 4.5 million, mortality 20%. And we were surprised. Then we read up the literature and found that this type of karyotype has a variable phenotype from the normal male to the ambiguous to the Turner. So we discussed the 2 reproductive options, that IVF with PGTA, because this can be picked up in them, and transfer of only girls, or IVF with donor. Couple decided to go ahead with the donor only. Then the PGTSR for the balanced translocation carrier. So is there any evidence? And there is a RCOG green top guideline in 2023, and that says that the time to pregnancy is similar in both the groups, whether they undergo the PGTSR or no. So the live birth rate, the conception rate, and the miscarriage rates, they are all similar whether PGT or non-PGTSR. Then is there an evidence for the PGTA? Again, the same guideline, they suggest that live birth rates are similar between the PGTA and the expectant managements. So coming to the products of conception, and what are the tests which we used to do, the karyotype, the FISH, but recently the microarray is the test of the choice. And very soon, probably the microarray we will be replacing by the exome sequencing. But till now, we are still doing the microarray. So the microarray testing should be done whenever the ACOG and the Society of Maternal Fetal Medicine says that, whenever the chromosomal analysis is done for the fetal purposes, in the cases of congenital abnormality or fetal demise, it should be the CMA should be the first year test in any antenatal testing, whether the amniocentesis or the product of the conception. And so then why do they say that? What are the advantages of the chromosomal microarray? The success rate of the microarray is 95% versus the 68% for the karyotype. And they have about 5% extra diagnostic yield in the microarray. And that's why the POC microarray is a first year test for this. So what is a microarray? DNA microarray is like a computer chip, and which are arrayed on a glass surface. And these DNA fragments, they are the DNA probes, and the size of these DNA probes of about 25 to 80 base pairs. And our human genome, that contains about 3 billion base pairs. So a DNA microarray probe will require multi-million probe. So all these arrays are for the clinical purposes. They are designed intelligently to cover both the coding and the non-coding functional gene to detect the copy number variations. So they detect the aneuploidy, the gains, the losses, and the unbalanced rearrangements. There are basically 2 types of microarray, the CGHS and the SNP microarrays. All these, the microarray, they have about 3 million probes, depending upon the probe number can be different. And the probes are fluorescently labeled, and the test DNA is hybridized, and the signal intensity. So there are different type of probes, and the copy number variations can be more than 200 kb for the deletion, and they would report for duplication. The reporting is about more than 400 kb. And there are various CMA platforms. Mostly we use the Efimetrix platform for the microarray. So the microarray, which is used for the clinical purposes, they have a high concentration of the probes targeted to the areas with well-defined microdeletion or microdeletion duplication syndrome. They also include a backbone of the probes which are arrayed at equal intervals across the rest of the genome. Clinical laboratories which are performing the microarray, they usually report the copy number variations in the targeted clinically significant regions, which are 50 kb or 100 kb. And the backbone probe allows for the identification of the copy number variations in the prenatal studies is often set at the more than 1 MB. So the reporting is pathogenic, likely pathogenic, and the very benign and the variation of the uncertain significance. So what is the advantage of the CMA? The biggest advantage is the maternal cell contamination. So many a time when we send the product of conception, it may be the, particularly in the early, like 6-7 weeks of the pregnancy, mostly this is contaminated with the maternal cell. So this test will go wrong. So before doing any microarray testing, this is the test which is done. This can also detect the uniparental disomy. We can see here that this is a case of uniparental disomy. So there are advantages versus the CMA versus the karyotype, that the resolution is very, to the tune of 50 to 100 kb, whereas the karyotype has a resolution of about 5 MB, and there is no need of culture, and the turnaround time is usually around 3 to 5 days, and it can detect the UPD, but the biggest disadvantage is cannot detect the monogenic disorders. Then after the chromosomes, we come to the single gene disorders, which are relevant for the recurrent abortions, and they include myotonic dystrophy, homozygous achondroplasia, some of the autosomal recessive disorders, congenital arthrogryposis, Smith-Lemli, some X-linked dominant disorders like Rett syndrome, Aicardi syndrome, incontinentia pigmenti. And this is a case with the incontinentia pigmenti. We can see here, this is an X-linked dominant condition. So there are male lethality here. And this mother came during the pregnancy. And these are the inherited thrombophilia. So as per the RCOG latest guideline, they say that the women with the second trimester miscarriages may be offered testing for factor V lead-in prothrombin gene protein S, ideally within a research context. So the factor V lead-in, they say that they can be associated with the first and particularly the second trimester recurrent miscarriages. Prothrombin gene may be recurrent miscarriages. Protein S is not demonstrated. Protein C, no association. And MTHFR has got no association with the recurrent pregnancy loss. So in the recent evidences, we can see that factor V lead-in, prothrombin gene, and protein S may be done as a second-tier test for the recurrent pregnancy loss. And this is a case where the karyotype, ultrasound, autoimmune, all workup was normal. Then we did the factor V lead-in mutation, and this was heterozygous. We put her on heparin, and then she delivered a normal, healthy male. And this is common. The risk of thrombosis is 5 to 8-fold. And in a meta-analysis by the Ray et al., the late pregnancy has a higher association vis-a-vis the early pregnancy, and the management is low molecular weight heparin. Then with the NGS touching the clinic everywhere, so for the recurrent miscarriages also, there are recommendations in the literature, and the various uses are trio, that is the mother, father, and the POC. It can be also done only for the POC or for the couple or only for the female partners. So how do we utilize this? Where do we use it? So like this is a lady with the para 0+3, and her karyotype was normal, all her workup was normal. So we did the clinical exome sequencing, and that shows that there is a biallelic variant in the NLRP7. So she's already having the 2 mutation, as she's a compound heterozygous. And literature shows that the women with the biallelic variant, they fail to establish the imprinting in the oocytes, leading to the recurrent pregnancy loss or the recurrent molar pregnancy. So the option is the donor oocyte. So how do we detect that who are the women who will need the whole exome sequencing? So apart from the microarray, we also do the histopathology of the product of conception. And if there are molar changes, we suggest them to go ahead with the whole exome sequencing. And this is how we have started doing even the NGS for the recurrent pregnancy loss. And how to send the product of conception. It should be sent in the normal saline. Ideally, it should be sent in the RPMI medium, but this is not practically possible. So sterile normal saline. And if you want to just send a chunk of the placenta, then this should be near the cord, and about 25, 50 coin size. It should be given in the normal saline at the room temperature and transported to the lab. So to conclude, the first level of investigations for the recurrent miscarriages, we include for the anatomical causes, the ultrasound, the 3D scan, the lupus, anticardiolipin. Lupus anticoagulant should be checked by the two methods, both by the APTT and the DRBBT, and then thyroid function test, diabetes, parental karyotyping, and the microarray. And in the second tier of test, we suggest ANA and factor V Leiden, prothrombin gene, and protein S, antithrombin 3, and also the sperm DNA fragmentation index. And despite all these investigations, sometimes even the clotting bleeding disorders also may cause the recurrent pregnancy loss. And here we need to involve the hematologist to assess all these assess factor 13, factor 8, clot retraction, so as to identify the women, those who have a bleeding disorders. And this is how we cytogenetic testing in the algorithm in the recurrent pregnancy loss. So if the lady is non-pregnant, then the karyotype of the husband and wife should be done. And if she is has come with the abortion, then it's must that the POC microarray should be done, and then be followed by the workup of the RPL. So to conclude, couples with 2 or more pregnancy losses, they should be evaluated for the recurrent pregnancy loss, both the cytogenetic and the non-cytogenetic. And the CMA on the product of conception with the MCC should be the first year test for the all POC. You can do even for the first also, that suppose the first explains that this is trisomy 16, then this gives a closer to the woman. So we can even do for the first also, but the guidelines suggest about after second, at second POC, and then it will be only unexplained in 10% of the cases. And couple should be offered karyotyping. We should not do the microarray testing in the couple, because the microarray cannot check the balanced translocation carrier. And for couple, we are interested in the balanced translocation carrier. So the microarray for the POC and karyotype for the couple. And in cases of the balanced translocation, the live birth rates are good with the expectant management, though IVF with PGT can be considered in women with decreased fertility, and women with sex chromosomal abnormalities like XXX, Turner mosaic, they can have healthy offsprings, and the low pass genome sequencing may prove in the near future as a turning point. This is the paper which I normally read up for this. This is the latest published in 2023. Thank you, everyone.
Thank you, madam. Thank you for the excellent presentation with a very, very good informative slides, ma'am.
Thank you.
RPL cases are very difficult to treat, but after listening to your lecture, I think it becomes easier for us, ma'am. Thank you. Thank you very much, ma'am. And the questions, as usual, it will be written in the chat box and it will be answered through chat box. So thank you, ma'am. And let us go to the next session.
Thank you so
Thank you.
much.
Thank you so much,
madam.
ma'am.
Thank you.
Now
Thank you,
we move on to the second session for the day. For that, I would like to invite our chairpersons, Dr. Rashmi Madam and Dr. Deepa Gupta Madam. Can I have Rashmi Madam's slide, please? So Dr. Rashmi Madam, she's consultant obstetrician
Thank
and
you,
gynecologist.
Thank you, Arti.
Amravati.
Thank you.
Yes, ma'am. Welcome, ma'am. Thank you so much. And Deepa Gupta Madam, she is chairperson, Community Health and Public Awareness Subcommittee of AOGD. And
thank you, Dr.
ma'am,
Pooja.
welcome so much.
Thank you, Dr. Aarti.
Rashmi ma'am to introduce our first speaker.
It's a great honor to introduce Dr. Veronica Arora. Dr. Veronica Madam, she is consultant clinical genetics at Gangaram Hospital, and she has been awarded certification from European College of Medical Genetics. And she is the co-editor of Foxy Focus Fetal Medicine and Genetics, and also she is on the advisory board of Myositis Society of India. Her areas of interest are reproductive genetics, RPL, fetal malformations, autism, skeletal dysplasias, and dysmorphology. It's a great honor, madam, to have you on board. And I would like to invite you for your talk.
Hi, good evening, everyone. It has been a great learning for myself during this course as well. And thank you, the organizers. Thank you, Sita ma'am, for having me here today. So, I'd be talking about the approach to primary amenorrhea. Being a genetics person, I'd be focusing on the genetic aspects and the genetic disorders related to primary amenorrhea. I hope my slides are visible.
Yeah, absolutely. You can make it full screen, ma'am.
Yeah, thank you. So let's start with the
Yeah.
definition, and I'm sure all the residents who are here today already know the definition, but there was a change when I was studying obstetrics, that primary amenorrhea is the absence of menstruation in a female of reproductive age or earlier, which is characterized by no menstruation by age 15 with secondary sexual characteristics or 3 years after thilarche, or no menstruation and absence of secondary sexual characteristics by age 30. So, did you know that the genetic variants or the genetic mutations are responsible for a large number of primary amenorrhea cases? So, this significant percentage does vary, and the literature gives a approximate percentage of 10 to 15%. The impact on treatment decision of identifying a genetic disorder is huge. Genetic testing results can influence treatment options. For instance, in identifying a condition like Turner syndrome may lead for us to give a hormone replacement therapy to develop secondary sexual characteristic. Identifying a mosaic Turner can help us to store the ovums before they reached a stage of complete amenorrhea and infertility, and they can actually have children. Identifying a genetic cause can also help us to help the relatives that may also be suffering from a similar disorder, maybe in a milder form, because genetic testing is characterized by a huge phenotypic variability, which means that each person in a family who's suffering from a genetic disorder does not have to be as severely affected as the other. So let's learn a little bit, recap a little bit about genetics, which I'm sure you all have been studying through these days. So a genetic nomenclature or the genome consists of 23 pairs of chromosomes. Out of these, we have one pair of sex chromosomes, which could be XX or XY. So this XX and XY is what is all our genetics of primary amenorrhea is related to. The Y chromosome is also important because we have some SRY rearrangements that can be present on the X chromosomes also. So the two types of genetic testing that we perform is the cytogenetic test and the molecular genetic test. Cytogenetic tests are to know the number of chromosomes and to know if some chromosome is deleted or some chromosome is extra, or a part of chromosome is deleted or extra. When we have the first major test, which is known as a karyotype, it looks at all chromosomes arranged in the descending order of their size. It's a very basic test, only tells us about large deletions of the chromosomes or large duplications or presence of an extra chromosomes or a missing chromosome. If we want to look at smaller parts of the chromosomes like exons, we need to do other tests like a microarray or an MLPA. So, this is the basic test that we do in most cases of primary amenorrhea. You can do this as a first test. The disadvantage of this test is smaller deletions are missed, and another disadvantage is that it will give you all the information, not the specific information per se. If you have a high suspicion of a disorder, then you can also order a test called FISH. That FISH test will give you the targeted information for that particular disorder. Once we have tested for chromosome using a karyotype or FISH, then we move on to genes. So exomes are regions of the genome that are known to encode protein. And these exomes constitute 1 to 2% of the whole genome. But very interestingly, they contain 85% of the disease-causing genes. So if we want to look at all the 85% of disease causing genes together, we can do this test, which is known as exome sequencing, which is the targeted sequencing of nearly every protein coding region and may be helpful in detecting genetic disorders when the karyotype and the tests of the chromosomes are unraveling. So this is the gene structure. And the gene structure consists of a coding and a non-coding region. When we look at the coding region, which contains the 85% of the important information, it is known as exome sequencing. So when we want to understand if there is any mutation in the gene, we can do this test known as whole exome sequencing. A clinical exome sequencing looks for a limited number of genes related to our phenotype only. Let's move on to primary amenorrhea now and start as with the etiological classification. So etiological classification, of course, starts with the anatomical defects, then the hypothalamic and pituitary, ovarian, hormonal, and miscellaneous disorders. The HPO axis, as we know, is prime to understand the disorders of the primary amenorrhea. It starts with the hypothalamus, which releases the gonadotropin releasing hormone. Then we have the pituitary, which releases the LH and FSH. And finally, the gonads. In females, the ovarian gonads, and which release the estradiol and the progesterone. And then finally, we have the outflow tracts. The outflow tracts abnormalities we will discuss later. The basic requirements for normal menstruation is the functioning of all anatomically and functional distinct structure components, that is the aforementioned the hypothalamus, pituitary, ovary, and the genital outflow tracts. Any problem in any of these components can cause primary amenorrhea. So easy to remember, just remember the HPO axis, and one by one we will understand the disorders of HPO tract development and how they cause primary amenorrhea. So let's start with the most basic, the anatomical defects. In the anatomical defects, I'm sure you've all seen a case of the Mullerian agenesis syndrome, also known as the Mayer-Rokitansky syndrome. So the genetic basis of it is not very well understood, but now more and more genes are being implicated for the same, and now we do have susceptibility genes for this. So Mullerian duct agenesis results in a complete or partial absence of the uterus, fallopian tube, and the upper one-third of vagina. Patients typically have normal ovarian function and external female genitalia, but due to the absence of the uterus, there is no menstruation. Then we have certain enzyme defects and receptor anomalies. These enzyme defects again can lead to an ambiguous genitalia and differing levels of various hormones that are needed to be present normally. Important condition to be noted in the enzymatic defects and receptor anomalies causing an anatomical abnormality is the androgen insensitivity syndrome, in which individuals with 46XY karyotype will have a mutation in the androgen receptor, leading to complete androgen resistance, causing development of external female genitalia but absence of all the Mullerian structures. So easy to understand is that if you have a tall looking beautiful female coming to you with primary amenorrhea, important to do is a karyotype, and by chance if you're finding the karyotype to be 46XY, that is a male karyotype, a strong suspicion of androgen insensitivity syndrome should be made. But is the diagnosis of androgen insensitivity syndrome just by the karyotype? The answer is no. We need to do further genetic testing for the androgen receptor presence or absence by a sequencing test. Only then we can diagnose the complete androgen insensitivity syndrome. Then we have congenital obstructions of the menstrual flow tract, as in an imperforate hymen or transverse vaginal septum and a isolated agenesis of the vagina. So these seem like they'd be easy to pick up, but they are missed a lot of times and are common presentation in the gynac OPT. Another big group of disorders known as disorders of sexual development. They include genetic or developmental conditions leading to abnormalities in the formation of reproductive tracts or external genitalia. So whenever there is a discordant of the phenotypic sex and the genotypic sex, it is pertinent to think of disorders of sexual development. So here we had a glance on the anatomical abnormalities, that is the disorders which present with an anatomical abnormalities. The etiology for each of the disorders, as I discussed, is different, but they will all have some problem in the uterus or in the outflow tracts. Next, we come on to the hypothalamic and the pituitary disorders. So the first is the one that we need to always ask in our historical evaluation is the constitutional delay of growth and puberty, a temporary delay in the menstruation, which is familial mostly. You ask when the grandmother achieved their pubarche, thilarche, etc., and you have an answer. This typically resolves over time with normal puberty onset, which is later than average. Then we have a functional hypothalamic amenorrhea, which is a pathological suppression of the reproductive cycle due to insufficient energy, commonly used by disordered eating, excessive exercise, or stress, associated with low levels of GnRH, leading to reduced FSH and a lack of menstruation. So a treatable condition by omitting these factors, and we know that bulimia and anorexia has been known to cause amenorrhea. So another important history that should be taken. Coming on to a genetic disorder, that is Kallmann syndrome, a genetic disorder leading to absence of GnRH anosmia. It is caused by non-functioning genes, which causes the GnRH to not get produced and released, and this has anosmia as an important finding here. So we have a history of constitutional delay, a history of eating disorders, and also a history of anosmia to be taken to come on to an really lower down to the in the disorders of hypothalamus. Then we have the disorders of pituitary and hypothalamus, specifically for the pituitary, which include the pituitary adenomas. These can lead to elevated prolactin levels. Another important investigation in case of primary amenorrhea, infiltrative diseases of the pituitary, including autoimmune diseases, craniopharyngioma, sarcoidosis, and pituitary infection or necrosis. You can order a targeted MRI for pituitary so that they do always order this. An empty sella syndrome, a common finding, does not always cause this, and it may be a common variant as well. So we studied about the anatomical defect, the disorders of the hypothalamus pituitary. What comes next is the ovary. So the disorders of ovarian dysfunction, the first and foremost is the dysgenesis of the ovary itself, known as the gonadal dysgenesis. It is a condition where the ovaries fail to develop or function properly, leading to the absence of menstruation. Turner syndrome 45X. So again, you do not say it as 45XO, just say it as a 45X. It is a common cause of ovarian failure because of the accelerated decline in the number of oocytes starting at birth. It leads to ovarian failure and non-functional ovaries and primary amenorrhea. A condition known as mosaic Turner syndrome, something that we all must keep in mind because the former is easier to pick up, but the mosaic Turner may have other abnormalities also. It is a variant where some cells have a normal chromosome set, but others have monosomy X, leading to a various degree of ovarian dysfunction, and pregnancy outcomes have been described as well. Another important point here is when a lady with mosaic Turner syndrome comes to you in pregnancy, it is important to not do NIPT for her, because NIPT is more likely to be Turner's also for this lady, and this will be a false negative NIPT. So if you have a lady with mosaic Turners who wants to have a baby, go for a combined dual marker, which is the standard of care aneuploidy testing. Then we come on to Swyer syndrome. It is a 46 karyotype, 46XY karyotype again. That is the genotypic male sex. Individuals with non-functional gonads that fail to secrete AMH and testosterone, resulting in the development of female internal and external genitalia, but lack of secondary sexual characteristic at puberty. So you can differentiate these from androgen insensitivity, because in androgen insensitivity, the secondary sexual characteristics have developed, but in Swyer, they are not. So girls with primary amenorrhea 46XY, we should look and differentiate by the secondary sexual characteristic. Next, we come on to the primary ovarian insufficiency. So the ovary may not be functioning since birth, known as gonadal dysgenesis, gonadal agenesis, or they may start to non-function, or their function may stop later, known as a primary ovarian insufficiency. Conditions leading to early ovarian failure and cessation of menstruation before 40 years is what is the definition of POI. Important causes include secondary causes like autoimmune diseases, chemotherapy, radiation, or primary causes like the genetic causes, as in Turner syndrome or a fragile X carrier, that is the FRM1 gene mutation carrier. Another disorder, that is the aromatase 17 alpha hydroxylase deficiency, can also cause ovarian hormone production failure and contribute to primary amenorrhea. So these are the common causes of POI. So after discussing the HPO axis, that is the hypothalamus, pituitary, and the ovary, now we come on to the hormonal abnormalities affecting the HPO axis. These are the common ones, including hyperandrogenism, as in PCOS, congenital adrenal hyperplasia, which is the non-classic variety, androgen secreting tumors, and Cushing's. Hyperprolactinemia, as in the prolactin secreting tumor of the pituitary. Elevated prolactin does separate the GnRH secretion and causes amenorrhea. The thyroid imbalances and the poorly controlled diabetes. So hormones, important evaluation and must be looked at. Then we have certain physiological and medication-induced amenorrheas. These includes pregnancy, of course, we know that, and lactational amenorrhea, important to remember and asked in history. So these are secondary, obviously. So, and other cause of secondary amenorrhea like hormonal contraceptive, chemotherapy, radiation, and antipsychotic medications. They are less likely to cause primary, but a secondary amenorrhea. So, when we talk about amenorrhea, if the patient has had any menstruation, we asked for the history of the last menstrual period, which is important. Sometimes they may give a history of spotting, etc. in primary amenorrhea. Then you ask about history of breast and sexual hair development. Inquire about any presence of cyclic abdominal pain and suggesting outflow tract obstruction. So in imperforate hymen, these girls will tend to have a pain every month but no bleeding. You review the medical history for chronic illnesses, chemotherapy, radiation exposure may be very early in life causing a primary amenorrhea, eating disorders, and athletic training. Investigate any symptoms like anosmia, galactorrhea, headaches, visual changes. Look at the eyes, ask for any history of vision abnormalities, and consider family history, a 3-generation family pedigree for similar disorders, for 1 constitutional delay in puberty, and for 2nd for complete androgen insensitivity syndrome. Then now we come on to examination finding, what you want to look at. So of course we look at the height, weight, BMI, giving us a clue on too less or too much weight. So many disorders that I have discussed, indicators for gonadal dysgenesis, potential malnutrition related hypothalamic amenorrhea. You look at the head and neck for focal neurological deficit, thyroid abnormalities, thyroid dysfunction, and conditions associated with that. A deep evaluation of the skin, hair, and dress for for appearance of sexual maturity, a Tanner staging of breast development, any galactorrhea that you see can help in ruling in or ruling out the disorders that we just discussed. A cardiovascular examination for heart, lung, and blood pressure, especially to rule out condition of Turner syndrome, one of the most common causes of primary amenorrhea. For Turner's, you also look at the webbed neck, you look at the fifth finger, and that's how you make a diagnosis of Turner. You look for any palpable masses of hepatomegaly and any pelvic masses that you may record for any of the obstructions that may be present. Pelvic examination for external genitalia, internal examination, and bimanual examination to look for any obstructive abnormalities. So the workup, once you have done a good etiological examination and clinical history, you will be able to come to a differential diagnosis much easily. And then you can order the initial diagnostic study for all patients, a urine pregnancy test. If you are not sure it is a primary amenorrhea, also a pelvic ultrasound, serum FSH, LH, and estradiol to look at which part of the HPO axis is blocked, serum prolactin and serum TSH for all patients. Then we come on to the more specific test to rule out hyperandrogenism with total testosterone and 17-hydroxyprogesterone, to rule out chronic diseases, a general testing like a CBC metabolic profile, and to rule out a gonadal dysgenesis, Turner syndrome, or androgen insensitivity, as well as DSD. The first investigation you must do is a karyotype analysis. Once all this is normal, we can go and consider doing an MRI as well for looking at pituitary tumors. So this is one flow chart you can keep bedside, maybe in your OPD or bedside, to have a quick look at the disorders of primary amenorrhea. So the first thing to do is a history and clinical examination, a 3-generation pedigree, which I'm adding additionally as a geneticist. Then you look at a secondary sexual characteristic. If a karyotype analysis can be done, it's great. If the secondary sexual characteristics are not present, measured FSH and LH. If the FSH is less than 5, it is an hypogonadotropic hypogonadism, which is a hypothalamic disorder. If FSH is more than 20, it's a hypergonadotropic hypogonadism. You must go for karyotype analysis and think of Turner. If the secondary sexual characteristics are present, then you look at the uterus by an ultrasound if it is present or absent, and again do a karyotypic analysis. If the uterus is absent and the karyotype shows a 46XY, then it is an androgen insensitivity syndrome. If it shows an XX, then it is a Mullerian agenesis syndrome. If the secondary sexual characteristics are also present in the uterus or is also present, we are mostly looking at an outflow tract obstruction. And if the outflow tract is obstructed, then we think of the imperforate hymen and treat accordingly. If it is not, we evaluate again for other causes of secondary amenorrhea. So I don't have much time, but just a quick word about Turner syndrome. It is one of the commonest causes of primary amenorrhea. You do a maternal quad and a dual marker for pregnancy. NIPT does not have a good positive predictive value. This is how a Turner girl will look like. Short stature, frontal baldness, short stature will be present, and you will have some webbing of the neck with cardiovascular defects, and which are mostly iotic in nature. You can also order a test known as FISH for Turner syndrome, which is a quick test, provides a targeted testing for Turner syndrome. And whenever you order a FISH for Turner syndrome, ask for SRY. If there is an SRY that is present, it gives you a clue in the direction of maybe the girl may develop a gonadoblastoma and may need surgery for the same, right? So this is important to be done. So Turner syndrome karyotype indications include a fetal hydrops, delayed puberty, obstructive left-sided cardiac abnormalities, characteristic facial features, and if there is a infertility in a couple, even in the absence of a history of primary amenorrhea. Fragile X primary ovarian failure, if there is a girl who comes with primary ovarian insufficiency or primary amenorrhea, this is an important test to be done. The test will not be picked up by karyotyping or by exome sequencing. You need to order a separate test known as Fragile X TP-PCR, How will you suspect this? By asking for a history of intellectual disability in boys in that same family, because this disorder causes intellectual disability in boys and primary ovarian insufficiency in girls. So we can make it a routine just to ask for history of mental retardation or intellectual disability in boys. Another syndrome of POI is the blepharophimosis, ptosis, and epicantthus inversus syndrome, where the girls may have primary amenorrhea or secondary amenorrhea, and they're characterized by these really small looking eyes with blepharophimosis and ptosis. So, finally, my last two slides about which test to do when. So, karyotyping we do whenever there is a short stature, an elevated FSH, classical stigmata of Turner syndrome, absent Mullerian structures, a family history of genetic disorders, ambiguous genitalia, or discrepancy between the genetic and the phenotypic sex. We do an exome sequencing when, after even doing a karyotype, we don't have a diagnosis and the amenorrhea is idiopathic. Again, when we have Mullerian agenesis and we are not able to come to a diagnosis, when we are looking for some causes of gonadal developmental genes, we can also do exome sequencing. An unexplained hypergonadotropic hypogonadism, family history of genetic disorders like Coleman syndrome, and complex cases with syndromic features. If you find other features in a child, like a developmental delay or any malformation in addition to primary amenorrhea, we must go ahead and do exome sequencing. Except the karyotype and the exome sequencing, the additional test that may be ordered is a fragile X TP-PCR if there is a family history of intellectual disability. And sorry, this is not S. So MLPA for androgen insensitivity and MLPA for Prader-Willi syndrome if the features are suggestive of the same and you do not get a diagnosis in exome sequencing. So the flow could be a karyotype followed by exome followed by these tests, or in any order depending on the clinical evaluation and history. So the take home messages would be think genetic so that we can order an appropriate test. And as no one genetic test fits all the disorders, we need to choose our test very wisely as these tests are expensive. The interpretation of these tests is as important as ordering. Just something that comes up on a genetic test is not definitively going to be causative, and there are lots of variants of uncertain significance. Family history and screening is most crucial because once we have got the diagnosis, it becomes our duty to go ahead and help other family members who may be suffering from a maybe a milder form of the disorder also. So thank you so much. I hope I did not take too much time. And thank you for the opportunity. And I hope the things are clear.
Thank you so much, ma'am. That was quite it's a difficult topic which you've made very simple. So
Thank
would
you,
go
Dr.
on.
Veronica, madam, for this extensive and elaborate talk. What I understand from this beautiful talk is that the list of the causatives is extensive, and we need to go for compartment-based or systematic diagnosis and approach to this problem. What is also important is patient care. Why? Because the patient is going to require lifelong management in terms of hormone replacement, fertility issues, weight, and sexual dysfunctions, etc. So thank you so much. It was nice listening to you.
Thank you, ma'am. I would now request Deepa Gupta ma'am to introduce our next speaker.
Good evening, everyone. Now the second topic for this session is inherited cancer. And we have a very learned and decorative speaker, Dr. Srilata Nayar. She's MSc, MPhil, PhD. She's Lab Director, Department of Medical Genetics, Lifeline Multispecialty Hospital. She's consultant genetist, and she has more than 20 years of experience in diagnostic genetics. And she's a Chief Scientific Officer, IGCS, and she has got various publications to her credit in many national and international journals. Welcome you, madam.
Thank you. Thank you, Chinmay madam. Thank you, ICOG faculties and the esteemed chairpersons for giving me this opportunity. I'm humbled. After having heard about such interesting topics in genetics, now it is time to move on to a very, what do you say, a dry topic probably, or I'll try to make it interesting in the next 20 minutes. So my topic is on inherited cancers. So usually the genetic consultation from the obstetric point of view or from the gynecologist.
You can make it full screen. Dr. Srilata, you can make it full screen.
Yeah, 1 second, madam. Now is it okay, madam?
Perfect.
So thank you once again. And let me just start with the topic that is today given to me is inherited cancers. Inherited cancers are usually being referred from the gynec or from the obstetric team when there is a family history or when the patient herself is suspected of a genetic etiology behind her cancer. So genetic consultation for cancer syndromes or cancer predisposing syndrome is not usual, but it is not becoming rare nowadays. So now going on to the basics of cancer genetics. Cancer genetics is nothing but when there is an abnormality at the cellular level. So what to analyze in cancer genetics? Is it the chromosomes or is it the genes? Usually for a Philadelphia chromosome in an AML or in a leukemia cases, we can do a chromosome analysis to find out a Philadelphia chromosome or a FISH analysis to see there is a BCR-ABL fusion or not. But when we are talking about hereditary cancer, it is actually the problem at the gene level, that is at the DNA level. For that DNA level testing, we need to go for specific gene targeted testing or multi-gene testing. Now, if we look at the normal cell as well as the cancer cell, both are looking same, at least at the initial stages. The nucleus, the membranes, the plasma membrane, the intracellular organs, everything looks same. The only difference is that out of the same genes which they share between the normal cells and the cancer cells, one of the gene is mutated. And this mutation at one of the genes out of the 30,000 genes which is present between the normal cells and the cancer cells, one of them is turned on or either it is turned off. That leads to an uncontrolled cell division, and that is the genetic basis of cancer. So which gene is activated, which gene is inactivated, we'll be discussing in the next few slides. To begin with, just a quick introduction about the germline versus the somatic mutation, because I see a lot of confusions when there are referrals that whether we have to look for germline or whether we have to look for somatic mutations. Now, germline means the mutation has occurred either at the gamete level or just after fertilization, that is at the zygotic level. So if the mutation has occurred either in the gamete or in the zygotic level, that means when the zygote develops into the embryo and later on into the fetus or as a child or into as an adult, all the cells in the body are mutated with that particular gene. This gene could be either a tumor suppressor gene or it could be a proto-oncogene which is converted into oncogene. That means when a germline mutation is there, all the cells in the body are having the mutation. This is called as the germline mutation. So in germline mutation, you take up cell, you take up saliva, you take up any sample, any tissue from the body, all of the cells are going to have the same mutation. But if we look at the somatic mutations, in somatic mutations means that it is not present in the gamete or at the zygotic level. It is present after the embryo formation. It has happened either at the just a second, I'm trying to, yeah. It has happened in one cell, either in one part of the body, or it has happened in the fetus stage or after the birth or soon after the birth, or I would say it can happen even in the adulthood stage. So in case of somatic mutation, that means the person is not born with that mutation. This has been either acquired due to exposure to certain carcinogens or certain lifestyle changes. So somatic variants are not inherited ones, but these are mutations which has acquired later in the life, either in the fetal stage or in the childhood or in the adulthood stage, but they are not inherited. Now, if we take up the difference between the hereditary and sporadic cancer, simple to understand for the postgraduates or for the persons who are attending this seminar, most of the hereditary cancers are multiple. That means at multiple sites, multiple tumors. It could be bilateral, and most of the time they are early onset cancers. There is one case where a single male breast cancer needs genetic evaluation to suspect hereditary cancer and needs genetic evaluation. Now, if there is a family history, that means there are more than 2 affected members, either with the same cancers or related cancers, then you have to think that it could be hereditary. Based on the tumor pathology or based on the genetic result of a close relative, then also we have to think about hereditary cancer. For example, if a person has come with a brother or a sister's report saying that that person has got a pancreatic cancer and a germline pathogenic mutation, in that case, that individual, because that is a first degree relative who is affected, that person is also at high risk of having a hereditary cancer predisposition syndromes. Based on the family history, in Ashkenazi Jews, there is a founder mutation for breast cancer. So many of these Ashkenazi Jews are already having a hereditary predisposition. So it is with a great doubt we will have to offer them genetic testing if by chance they come to your clinic. Sporadic mutations, they are usually single tumors. That means they are present at only one site. They most of them are unilateral and they are later onset. That means most of the time these sporadic mutations are later onset, probably after 50s or after 60s. But most of the hereditary cancers, they are early onset. They can develop as early as childhood tumors or childhood cancers or young adults like 20s or in 30s. Now, when we talk about cancer, it is important to just quickly tell about their multifactorial also. It would be interesting to say that, there are certain cancers which are more common in certain population living in certain areas. Like, for example, in Canada, there is a place called Newfoundland, where there is an increased incidence of lip cancer. Whereas in US, there is a place called as Iowa, where there is multiple, there are many people who are having colorectal cancers. Coming back to India or coming back to Mumbai, if we see the big city like Mumbai, we will be able to see it is not these kind of cancers, but it is the breast and the ovarian cancer, which tops the list, followed by colorectal cancer. So there are not only genetic factors, but there are environmental factors. There are multiple factors which causes the genes to become cancerous or the person to develop a cancer. Now, it will be impartial if I don't tell quickly about Knutson's two-hit hypothesis. Now, Knudsen was working on retinoblastoma, and he was surprised to see that, there are certain children who have developed retinoblastoma, that is the retinal cancers at a very young age. Just soon after birth, they could see that there are certain children who have got retinoblastoma bilateral. And with his extensive study, he could hypothesize Knutson's two-hit hypothesis model, where most of the sporadic cancers, they are not inherited cancers. That means the person in both the alleles have normal genes, and there is one hit, like a lightning striking at one place. There is one mutation which is happening in one of the alleles, followed by a second mutation, which will make both the alleles having the mutation, and that leads to cancer. This is all after, this is in sporadic, that is after birth. But in case of those children who had very early onset, that is immediately after birth, they had bilateral retinoblastoma. In those children, they were born with a mutated copy from their parents. That means they had inherited one of the muted copy from the parents in RB1 gene, and a second hit led to a second mutation in the same gene, and that led to bilateral retinoblastoma and an early onset of retinoblastoma cancers in these very small children. So Knutson's two-hit hypothesis is to basically to understand that it is important to understand that there are 2 hits needed for the cells to become cancerous. That means uncontrolled cell division. 1 hit is the initial one. The second hit, 1 hit makes it susceptible for cancer. Second hit is the second hit is important to make it uncontrolled cell proliferation. Now, the same thing I'll make you understand in a different manner in the next slide. Now, if you look at the cancer genes, there are 3. It can be divided into 3 classes. That is the proto-oncogene. Proto-oncogenes, they normally promote normal cell growth, and mutations convert them to oncogenes from the proto-oncogenes. Tumor suppressor genes, they normally restrain cell growth. They are inhibitory in their action, and loss of function mutation results in unregulated growth. Mutator or DNA repair genes, these are the third category of cancer genes. When they are faulty or when they undergo mutations, that result in an accumulated rate of mutations. Now, quickly, the genes which are categorized into these 2, retinoblastoma, RB1, BRCA1, BRCA2, MLH1, MSH2, TP53, these are all tumor suppressor genes. Whereas oncogene, one of the example is RET gene, which is present in multiple endocrine adenomatosis type 2. I'll show you an illustration so that it is easy to understand what is the difference between the tumor suppressor gene and the proto-oncogene. Let me begin with proto-oncogene first. In proto-oncogenes, consider this as our life or a normal car, where both the brakes are functioning well. We are born with the normal genes. The proto-oncogenes as well as the tumor suppressor genes, they are normally present in our cell. So the normal function of a proto-oncogenes is to regulate the cell growth. They tell, okay, they have got growth factors, and there are different factors that give signals to these proto-oncogenes so that they are able to tell the cell to undergo cell division, to go into the S phase and into the M phase, like that. So in normal scenario, both the cells, both the copies are normally present. Now, suppose if this car has got the front brakes gone for toss, either because of a genetically or an inherited condition, or because of some technical problem, the brakes don't work. Similarly, if the first mutation has happened and in one of the allele, so that the proto-oncogene becomes oncogene, and that leads to brake failure, and boom goes the car, crashes and becomes cancer, and that leads to cancer. Whereas in tumor suppressor gene, which is actually an inhibitor gene, inhibitor means that in normal scenario, these genes regulate cell growth. That means they tell the cells to undergo, a programmed cell growth. So they tell when the cell should go into S phase, G phase, etc. Most of the time, these tumor suppressor genes are inhibitory. That means when they are present, they don't allow the cells to grow uncontrolled. They tell, okay, when the cells have to undergo 2 times mitosis, 3 times, etc. is under the tumor suppressor genes control. So when there is a first mutation which has happened in tumor suppressor gene, that will lead to the brake failure in the front side. So the first mutation makes the car susceptible to that can lead to cancer. Or sometimes it is there is a possibility that a person is born without one of the normal copies of the tumor suppressor gene. That means the front brakes are already not working, and there is a second hit which has happened, and the second hit causes both the brakes to fail, and the car leads to an accident. So that means in the absence of tumor suppressor genes, that can lead to cancer. So 2 hits, 1 hit, now the scenario is multiple hits, because there are many such cancer predisposing syndromes where not only 1 hit has happened. Because of rapid cell division, many mutations accumulate, and as the mutations accumulate, the cells are growing in an uncontrolled manner, and they might metastasize into other areas also. This is one more slide, one more pictorial representation. Both proto-oncogene and tumor suppressor genes have mutation, but most of the proto-oncogene mutations are gain of function mutations, and they are autosomal dominantly inherited. Whereas tumor suppressor genes, they are like, the police. They say, don't multiply too much. And if there is a problem with the gatekeepers, that is the policeman, there is loss of function mutation, and that lead to the tumor suppressor genes are mutant, and therefore they are not able to control the traffic, and that leads to tumor. So this is about the basics of tumor suppressor gene and the proto-oncogene. We all know about the Angelina Jolie effect. Angelina Jolie, as a person, would have done so many things, but what made her, apart from her cinematic career, what made her reach the Time headlines is that she underwent double mastectomy and salpingophorectomy because she wanted to make herself cancer-free because she had a very strong family history. And I think it had a great impact on many societies, including in our Indian society, because she had an inherited BRCA gene mutation and her mother died of. So what are BRCA genes? BRCA genes are nothing but tumor suppressor genes. There are two genes, BRCA1 and BRCA2. BRCA1 is present on chromosome 17, and it has got about 24 exons, whereas BRCA2 is present on chromosome 30 and has got 27 exons. Mutations in both BRCA1 and BRCA2 can lead to hereditary breast ovarian cancer syndromes. Now, when to suspect that there is a need for hereditary breast and ovarian cancer syndrome to be tested, it is because the incidence is somewhere close to 1 in 300 to 1 in 500 women. But what is important to understand is that BRCA1 and 2 genes, if it is mutated, it is a highly penetrant gene and with autosomal dominant mode of inheritance. The function of BRCA1 and 2 is to repair DNA double-stranded breaks. When the DNA undergoes replication, there are small breaks and gaps which happen. These BRCA1 and 2, they go and modify or they correct those errors which has happened during the DNA replication. So if there is a faulty BRCA1 or BRCA2 mutation, these error correction never happens. And that results in accumulation of more and more mutation as the cells undergo further cell divisions. So BRCA1 and 2 gene mutation accounts to breast as well as ovarian cancer. If you look at the chart which I have shown here, is that what are the risk factors? Obesity, nulliparity, PCOS, age, late menopause. These are some of the common the lifestyle causes of HBOC. But then there are certain hereditary predisposing conditions also, which leads to HBOC. That includes family history of either a breast or an ovarian cancer, or a known case of hereditary non-polyposis colorectal cancers, etc. Again, one more thing I want to stress here is that there is a little difference in BRCA1 and BRCA2 mutation and the tumor pathology. BRCA1 mutations are usually bilateral. They are triple negative, and sometimes you might also see in BRCA1 mutation HER2 overexpression also. BRCA2 mutation, when present, these women will be having an early onset of ovarian cancer as well as BRCA mutation. About 8 to 10 years early to that of a normal woman who is supposed to have cancer. And one more interesting thing is BRCA2 mutation is not only related to breast and ovarian cancer, but it can also be a part of pancreatic cancer, melanomas, etc. BRCA, now if you look at the whole bunch of cancers, 90% of the cancers are sporadic. Only 5% is hereditary. And out of that 5%, HBOC forms the major crunch of cancers. Sorry. BRCA gene mutations are not common, but are not rarer also, as the new technology, genetic screening, as well as awareness is there. BRCA gene mutations are rarer, but as the mutations are present, the risk of breast and ovarian cancer, lifetime risk, is high in compared to the general population. This is for all the postgraduates to understand. These are 5 genes which you should be knowing: BRCA1, BRCA2, MLH1, MSH2, and TP53. These are very highly penetrant genes. So when they are present, it is clinically actionable genes. There are other genes also which might be present in HBOC, like RAD51C, NBN, STK11, PTEN, etc. There are moderately penetrant genes like CHEK2, PALP2, BRIP1, ATM, RAD50, etc. There are low penetrant genes like FGFR2, CYP1A1, etc. So I'm not going into all those jargon words for others to bore. Now, hereditary breast and ovarian carcinoma, there is being guidelines being put forth by ACMG, that is American College of Medical Genetics, has given a clear-cut guidelines for which woman to be screened for hereditary breast and ovarian cancers. That includes any woman who had cancer diagnosed at less than 50 years of age, triple negative breast cancer, more than 2 primary breast cancers in the same person, Ashkenazi Jew ancestry, more than 3 cases of breast and ovarian cancer. When I say ovarian cancer, it also, I have included fallopian tube and primary peritoneal carcinoma as well, pancreatic and or prostate cancer. I think you can get this list from the ACMG guidelines also, very beautifully being given. But if there is a single case of a male breast cancer, that itself warrants genetic testing. Let us take a pedigree chart and just quickly go through a case illustration. This lady, the one which is there in the arrow, is asymptomatic right now. She is just come for a genetic consultation because she has lost her sister at 35 years of age for breast cancer. And she had already had 2 children before she passed away. So she's scared whether she will develop breast cancer or she will develop any other cancers. Now, when I take up the history, she is no more available. So I go for the gene testing for this lady who has come, or who is the proband, or who has come for a genetic consultation. At that time, she gives me a history that her maternal grandmother died of some cancer. She is not very sure, but it could be stomach cancer. She also has a paternal cousin who had osteosarcoma and died young. Now, when I start evaluating, she was found to have a BRCA1 mutation. It is a likely pathogenic mutation in BRCA1, and it is already a known mutation. And the mutation in this gene leads to breast, ovarian, and pancreas, as well as prostate cancers. But we don't have anything to say that this could be because she's asymptomatic right now. She's already had 2 children. So all the surveillance, treatment, management, everything depends upon how the cancer is going to be screened in future. So when I was, she had come back to me after 3 months to say that her father has developed now CA prostate. Now with this particular history, now we know that it could be hereditary breast and ovarian cancer, where we know that prostate cancer is also part of BRCA mutation. So question arises, does all individuals with BRCA and BRCA2 mutations have the risk of HPOC? No. BRCA1 and 2 mutated patients or individuals, they have an increased risk of breast cancer, ovarian cancer, pancreatic cancer, melanoma also. But the male individuals also have a high risk for prostate cancer. So it is important to understand that in the first visit itself, if you take a detailed family history, I know as obstetricians, you are busy, you're very busy, but if you are able to get some information, then if you can quickly make a pedigree, then you'll be able to filter out which patients you need to send for a genetic screening or a genetic testing, and that will save the whole family. And because as an obstetrician, you are as like a family physician, you know the patient, you know the extended families. So getting a family history should be easy for you if you could just do some talking. Now, the interesting thing is that BRCA is a highly penetrant gene. So even if there is no family history, but if the tumor is suggestive of a breast or the ovarian cancer, it is better to get a genetic testing done. Pleiotropy. Pleiotropy means one gene affecting many different organs, like in case of BRCA. Variable expression. If you have the mutation, doesn't mean that every individual with BRCA mutation will have cancer. Only thing is that they are at higher risk of developing cancer. There might be some individual who have a mutation but go spotless throughout the life. Let us take up one such example. This is a big pedigree, a patient who was, this is in red arrow, she was referred to me because of a DUB. And if when we draw the pedigree, it was all a 12-member big pedigree. This lady's grandmother had 12 offsprings. And when I take up the history, this lady in the first generation, this lady had 12 offspring with 3 daughters with breast cancer, one son who died of pancreas, as well as she has got 1, 2, and 3 grandchildren with breast cancer. And now this lady, who is consanguineously married to her paternal side, where the history is, and she wants to know, before she has already completed her family, before undergoing further treatment options, she wanted to know whether she is at high risk. We did a genetic screening for this asymptomatic individual as of now, because nobody else was available for genetic testing, and we could get a BRCA1 pathogenic heterozygous variation. And based on this variation, we could convey it to the patient after proper counseling, and also to the oncologist, so that they can make a proper decisions about further risk-reducing surgeries, etc. What are the different types of genetic testing for HBOC? It is either a multi-gene panel, single gene, or a targeted testing. Like in this previous pedigree, we know the mutation, where it is. It is in BRCA1, we know the exonic position. So then in that case, in that family, extended family, we can offer a targeted family mutation testing. That will save a lot of money also. But if we are not very sure about the mutation, it could be BRCA1 or BRCA2. In that case, you can go for single or for 2 or 3 gene panel testing. But if you don't know, and if nowadays the practice is you offer a multi-gene bigger panel testing, so that you don't miss. So nowadays the panel testing has got about 52 to 56 genes in one panel. So any germline pathogenic variant in BRCA and BRCA1 and BRCA2 gene or related gene is diagnostic of HBOC. And most of the time it is heterozygous, but there can be a rarely homozygous situation, like in Fanconi's anemia and Wilms tumor, etc. Now, what do we do for genetic testing? We can take a blood, saliva, tumor tissues, cell-free tumor DNA, or even from the FFP blocks also, we can isolate the DNA. And usually the first line of testing is next generation sequencing, to identify the point mutations like nonsense, missense, etc. This is one such example where the lady had where she has lost her mother for stomach cancer, and she wanted to know whether she is at high risk. So we did genetic testing, and we could find out CDH1, that is for diffuse gastric syndrome, a deleterious pathogenic variant. This is her pedigree. This is the proband. Now she has lost her mother, maternal uncles because of CA stomach, CA prostate, etc. And when we did a genetic testing, she's asymptomatic right now, but she was found to have the same mutation. And her brother was also found to have the same mutation, but her sister was spared of the same mutation. So we did a family testing, and we could tell them that what are the risks involved and how we can plan the surveillance and future management. For those cases where the point mutations are not the cause, it is a big deletion. In that case, we will have to think of MLPA, long-range PCR, chromosomal microarray, etc. as the method of genetic testing. Now, the positive, negative results have gone. As per the ACMG guidelines, there are only 3 categories, that is pathogenic, likely pathogenic, benign, or no mutation. Now, pathogenic means these are clinically actionable. Pathogenic or likely pathogenic means these are clinically actionable. They have a significant impact on the cancer surveillance, as well as in the treatment and the management of either the symptomatic or the asymptomatic patients. It also gives us the clue that which are the cancer treatment modalities available, which are the drugs available, where it is available, etc. And surgical interventions like risk-reducing self-angiophorectomy, etc. can be planned, or when can it be planned, etc. The extended family cascade testing can be done based on the pathogenic or likely pathogenic mutation. But if it is a benign or no mutation being found in the genetic test result, it doesn't change the medical management. You need to you need to do a post-test counseling as well, and they might need a follow-up based on the family history or on the other risk factors. Now, one more important thing I want to tell here or stress the audience here is that many times we see that these genetic test results, the patient wants it over the WhatsApp or over the email without a proper post-test counseling. So I want to emphasize here, all those who are ordering these tests, please make sure that, for your own safety, to prevent any medical legal issues also in future, please do not share it through WhatsApp. Please, even if you want to share, it should be through the email with proper post-test counseling and with documentation. Now, there are VUSs, that means there is no pathogenic or likely pathogenic mutation now, but if there is a variant in the same BRCA1 or BRCA2 or related genes, but the pathogenicity, that is the status might change in future. So in that case, we might have to review after 1 year or 2 years, or if the patient comes with symptoms. Sometimes a reanalysis is also needed. Genetic counseling is important part and the thing of offering any cancer predisposing syndromes genetic testing. As obstetricians or as gynecologists, I would be happy to say that you are doing an excellent job by always motivating not only the patient but the mother, sister, the mother-in-law, everyone. You have in the obstetric practice, you have about 9 months seeing the same patient, the relatives again and again. So you can motivate, you can educate, even if the family history is not on your patient side, but if it is on the husband side or husband relative side, you can motivate, you can educate about genetic testing. You can give the information why the test has to be done, how, what is the results expectation. And very importantly, a consent has to be taken. The confidentiality needs to be taken care of. And if the person is tested positive, do we need to do a secondary confirmatory test, or the additional family members has to be tested, etc., has to be done in pre-test counseling itself. And if they go, they should come back to you within a week to think or say that, yeah, doctor, I want to get it tested now, or I'm thinking of getting it tested. So that is a good motivation. Post-test counseling, as I told you, it is important that these test results are not shared by WhatsApp. You have to give a post-test counseling, and this should be impartial counseling. And if you don't know about certain variant, how it is going to affect in future, in that case, we'll have to have a tie-up with the oncologist so that they can also help you out whether this mutation, because there are a lot of databases where these variants have been reported, but these variants, we don't know how they are, how these women are doing it, whether they have developed in cancer. They might not have a cancer when they were tested, but they might have cancer in future. So these are things which you need to counsel. Colorectal cancer, they are also coming under the group of colorectal cancer. Any person who has got a colorectal cancer diagnosed at age less than 50 years of age, that is before they celebrate their 50th birthday, is called as young. Okay, so colorectal cancer diagnosed after the 50th birthday doesn't mean that they are old, but it just means that if they have a first degree relative who had a colorectal or an endometrial cancer, in that case, we have to think about a hereditary or an inherited cancer. Synchronous or a metachronous colorectal or endometrial cancers in the same person. Colorectal cancer showing mismatch repair deficiency. These are one group of disorders which I'll be talking later. Colorectal cancers and 2 additional cases of any Lynch syndrome associated cancers in the same person or in close relatives. Colorectal cancers and 2 additional Cowden syndrome criteria in the same person. So blah, blah, blah goes the whole list. I think this can be later on taken up from the guidelines itself. Now, it will be impartial if I don't talk about the father of cancer genetics, that is Henry T. Lynch, after which the Lynch syndrome, or we call it hereditary non-polyposis colorectal cancer, is being named. The hallmark of Lynch syndrome is that the Lynch syndrome shows microsatellite instability in immunohistochemistry. What is microsatellite instability is that there is a mutation in the mismatch repair genes. That includes these genes, that is MLH1, MSH2, MSH6, PMS1, PMS2, and rarely check. The function of mismatch repair genes is that they are needed in the maintenance of the telomeres. So when there is mutation in the mismatch repair genes, like and that leads to microsatellite instability. That means the telomere, the end of the chromosomes become susceptible for extra number of mutations. And as they undergo more and more mutations, there is accumulation of these gene mutations that leads to uncontrolled cell cycle proliferation. So in Lynch syndrome, if all these genes are present in immunohistochemistry, that means the Lynch genes are perfectly fine. There is no need for gene testing. But if the immunohistochemistry shows the absence of these genes, that means there is a mutation, and in this mutation in the MMR gene may lead to Lynch syndrome. The interesting part is that Lynch syndrome is not only associated with colorectal cancer, but it can also be associated in women with endometrial cancer. And if endometrial cancer you are suspecting, and if your patient has, and if they're negative for these immunohistochemistry genes, then you have to undergo, or you have to tell the lady to get the MLH1 methylation testing also, because around few percentage of the endometrial cancers are also due to methylation of hypermethylation of MLH1 gene. This is a classical pedigree of Lynch syndrome, where you will find colon cancers, endometrial cancers, multiple generations affected. Let us take up the percentage-wise incidences. There are only these 6 or 7 genes, but you can see that this can be mutated and it can lead to any of these cancers, including kidney cancer, prostate, breast, endometrial, colorectal. So Lynch syndrome is a whole group, big group of cancers. For that, we need to do either a panel testing, or if you could do multi-gene panel testing, that is the best. Let us take up a pedigree quickly. Now, this gentleman, who was a 35-year-old, has approached to us, and he has already undergone duodenectomy, and his father already had CA colon, and they were actually coming to our infertility clinic.
We're running a little behind schedule. Sorry to interrupt.
Yeah, I'll just quickly finish. So
Yes,
this gentleman, since he had a very early onset of cancer, so we could do gene testing, and it was found that he was having mutation in 2 mismatched repair genes, that is MSH2 and EpCAM genes. And since it was a big deletion, it was not being picked up in next generation sequencing, we had to utilize MLPA. This is quickly just to see that this 2 is the normal diploid number. The red dots is in the one that shows there is a deletion. And there is multiple gene deletion, not one gene deletion. Quickly, Leaf-Rumeni syndrome. Leaf-Rumeni syndrome, this slide I have included just to scare all those people here, is that TP53 mutation is associated with Leaf-Rumeni syndrome. And loss of function mutation makes a 50-fold high risk of developing any type of cancer in their lifetime. And most of the cancers, they don't go after 50 years. Most of the cancers are early onset. This is the abbreviation for the sarcomas, breast, brain, leukemia, and retinocortical tumors. The important thing is that anybody having TP53 mutation, they need to be under surveillance very meticulously. And the interesting thing is there is predominance of TP53 mutation in females as well as in juvenile cancers. So TP53 mutation is important to understand that it should be part of your multi-gene panel testing, so that we don't miss these mutations. This is quickly about TP53 and its functions. I'm going to skip that. Cowden syndrome category criteria, or Cowden syndrome, is usually due to PTEN mutation. It is again a tumor suppressor gene. PTEN mutation also can lead to breast, endometrial, thyroid cancers, gastrointestinal cancers, etc. PTEN mutations are more commonly associated with breast, thyroid, and endometrial cancers. Endometrial cancer, I'm going to skip this, because endometrial cancers, if they are diagnosed at less than 50 years of age, they need genetic testing. And if it is they have been diagnosed at greater than 50 years of age with a family history of any Cowden, Lynch syndrome, etc., they need to be genetically tested. To conclude, hereditary gynecological cancer syndromes, they are a huge group. Gynecologists have a greater role in identifying which are the individuals who need genetic testing, and to counsel them out about their further management and patient care. The availability of clinical genetic testing pan-India has made an easy and early detection of high-risk patients and also their families. The recommendations can be based on with the oncologist. The hereditary cancer syndromes needs a multidisciplinary approach that improves the quality of care, support, treatment, and management of patients. And once they've been tested positive, they should be counseled about family members' cascade testing. Now, these are the 2 important literature which I have taken. And I would suggest that all the gynecologists please take a copy of this ACMG practice guidelines in your busy practice. If you have this copy handy in your table, it has got all the syndrome-wise classification as well as, the tables, which is for your easy, quick referrals. For quick referrals, and you can take based on your patient this thing. About 28 hereditary cancer predisposing syndromes has been covered in this ACMG practice guidelines. And also you have your ACOG practice bulletin as well as there are certain websites also where you can put in the mutations and you get the risk assessment being done. Thank you so much.
Thank you so much, ma'am. It was a very informative talk and everyone wanted you to go on, but unfortunately we have another session. But anyone who has questions, please post in the chat box and we'll pass them on to ma'am and then she can answer our doubts for us.
Yeah, one more thing, I'm very thankful to Chinmay madam for pushing me to take up this class, and a big hello to Dr. Fesi sir and to Dr. Narendra Malhotra sir, because I think I remember if it is 20 years back or so, sir was writing a chapter on genetics and I was a part of it. So thank you so much, and it is very interesting to see that many more and more people are now interested in genetics. Thank you so much.
Thank you, Dr. Srilata, for accepting this topic, because while we were making it, this was looking like a very difficult topic to address. And I think Dr. Sita will agree that, you've really done justice to the topic. And what's more interesting is the audience wanted you to go on. So I'm happy that they got the gist of it. Thank you so much, Dr. Srilata. Thank you.
Now we move on to the third and the final session for today, for which I would like to invite our chairpersons, Dr. Kalpana ma'am and Dr. Shraddha Agarwal ma'am. Can I have Kalpana ma'am's CV, please?
Can you share the slide
No
of
problem.
CV?
So Kalpana ma'am is National Coordinator for the Infertility Committee, FOGSI, and Post Director for Postdoctoral Fellowship in Gynae Endoscopy. Welcome, ma'am. Thank you so much for being here with us. Dr. Shraddha Agarwal, ma'am, she is the founder and past president of Palwal OBG Society, Haryana, and member of Press Committee, FOGSI, 2019 to 2021. Ma'am, thank you so much for accepting the invitation to be here with us today. I would request Kalpana ma'am to kindly invite and introduce our first speaker. Kalpana ma'am?
I think she is not.
Madam is unmute now.
No, now she's unmuted. Kalpana, madam.
Thank you. Thank you so much. Actually, it is my honor to be a part of this wonderful workshop organized by ICOG team under the leadership of Sunita Tandlwalkar, FOGSI President, Secretary General, Swarna Kadilka ma'am, ICOG Chair Parag sir, Vice Chair Ashok Kumar sir, and Secretary General Sarita ma'am. My sincere thanks to the conveners, Dr. Pooja, Dr. Chinmay, Dr. Sita, for inviting me for this wonderful workshop. Great topics had been selected and wonderful speakers sharing their knowledge. I'm going to chair a topic which is a really difficult topic. Genetics in DSD. It's my pleasure to invite Meenal Agarwal, Head of Medical Genetics, KEM Hospital Pune, Director Clinical Genetics, MedGenome Labs, and also her areas of interest is reproductive and pregenital genetics. She has got 42 publications and also written 4 chapters in book. Welcome, Dr. Meenal. Over to you for the wonderful talk.
Thank you, Dr. Kalpana. And at the outset, I would like to thank my senior and friend and colleague, Chinmayji, which I call her like this, and Dr. Pooja and ICOG team. In fact, I was not aware of this platform, and it is a wonderful selection of topics. So without any delay, let me start my presentation. Is my slides visible?
Yes,
Yeah,
ma'am,
you
they are.
can see your slides. You just have to make it full screen. Go to the view, and I think you can go there, huh?
No, I'm not.
View पर आ रहा ना?
Ma'am, just play.
नहीं ये
Yeah.
है play.
Yeah.
And how do I? No, this is visible to me. Okay, all right. So for next 20 minutes or so, I will be speaking about DSD. And for a 1-minute overview, I will take you through the spectrum of genetic disorders and tests, the terminologies of DSD, how it has been evolved from being called to pseudohermaphroditism, ambiguous genitalia, so on, intersex, and now there are more patient acceptable, and in fact, the terminology also reflects the pathophysiology as well. I will touch upon the embryology and pathophysiology of DSD a bit, so it will help our audience to make a flow of workup when they are looking at the child or any individual. Then the clinical spectrum of DSD, clinical workup, which might be suggested, more focus on genetic workup, and a couple of slides on importance of multidisciplinary approach. So how genetic disorders arise? All of us, we are all arising from a union of two cells, egg and the sperm. And at the time of egg and sperm union, half of the genetic material coming from each side. And this half of the genetic material is 23 chromosomes and about one copy of 25,000 genes which are residing on those chromosomes. And errors can happen anywhere. So even if everything else is normal in the family, no family history, no consanguinity, still 2 to 5% of every life-born child is expected to have a major genetic disorder. And if you look at the genetic architecture, it is made up of 23 pair of chromosomes, that is 23 into 2, 2n, which makes up of 6 billion bases, which is a whole genome. And out of those 6 billion bases, about 50 to 60 million, about 1% of them, they make sense, which are genes. And out of those genes, there are about 6,000 to 10,000 genes which are associated with some medical illness. And depending upon what kind of disease it is and what we want to look at. So imagine an entire encyclopedia, and if you want to look at the single spelling in the encyclopedia, or you want to look at the full chapter, or you want to look at the full volume, it is like a camera. So if you want a panoramic view, a low resolution, a very high resolution panoramic view, or you want to focus on a one spelling in the entire encyclopedia of the 6 billion alphabets, your genetic test refers. So coming on to DSD, DSD stands for disorders or differences of sex development and differentiation. I am not sure, which guidelines follow which word, but these words are interchangeably used across the publication, across the literature. So this is a mix of male and the female sexual characteristics. To define it, these are congenital condition where chromosomal, gonadal, anatomical or phenotypic sex is atypical. And these are few of the older terms which are being replaced by the newer terminology. Previously, we used to hear as an ambiguous genitalia. Now this is termed as atypical genitalia. Testicular feminization, undervirilization, intersex, hermaphroditism, pseudohermaphroditism, XX males, XY females, sex reversal. They are all replaced by a better pathophysiologically reflecting terminologies like 46XX something something, 46XY something something. So you see, the classification of these DSD, starts from a chromosomal complement. Each of these DSD's classification word, they starts from a chromosomal. So coming on to the pathophysiology. So I spoke about 3 words in my definition. One is a chromosomal sex. Second is the gonadal sex, where is the testis versus ovaries or versus combination of these gonads. And there is an anatomical sex, which is composed of an external genitalia as well as internal genitalia. and also includes the secondary sexual characteristics as well. The transgender, transvestism, they are psychological or gender dysphoria. This is beyond the scope of this presentation. And I will be focusing on the chromosomal, gonadal, and anatomical discrepancy in the sex differentiation. So sex determination and followed by sex development and differentiation is an intricate process of a series of events which happens highly meticulously. And if something happens wrong, there is a development of DSD. So first is the chromosomal sex. Chromosomal sex is formed at the time of fertilization, depending upon which chromosome is coming from the sperm. Whether this is an X chromosome or there is a Y chromosomes, there is a constitution of chromosomal sex in the zygote. Mostly this is 46XX or 46XY, but there can be one sex chromosome missing, like in Turner syndrome, one chromosome extra, like Klinefelter syndrome, or there can be a various mosaicism which gives rise to a spectrum of DSD. And how do you see the chromosomal sex? Use the gold standard test to look for the chromosomal sex is the karyotype. So from the single cell zygote, all the cells of the body derives. So if you are testing a blood for a karyotype, essentially you are testing what chromosomal sex was formed at the time of zygote, because blood is also developed from that zygote. The karyotype is gold standard, but as you all be aware, it takes about 2 to 3 weeks time. And imagine a newborn child whose parents are waiting for their gender determination, the revelation to their relatives. The karyotype may be cumbersome. FISH can be an alternative technique which gives you a chromosomal sex, especially the X or Y, in about 48 to 72 hours of time, though it cannot see all chromosomes at one point of time, but at least X and Y and the degree of mosaicism. FISH is a faster test, much faster than the karyotype. But karyotype is must in the evaluation of any individual with DSD at any age of presentation. Even if you have done the FISH for an early diagnosis, karyotype is must. So after the chromosomal sex is formed at the time of zygote, about 6 weeks of embryonic development, there is no gonads formation. Everything similar in males and females. By about 6 weeks, there are some genes, especially on the Y chromosomes, which is an SRY gene, which determines the formation of further internal genitalia or external genitalia. And it is a 46XX. This is an ovary. But if there is a kind of mosaicism, various degrees of Y chromosome in the various mosaic state, there can be ovotestis or testis or ovary on one side, ovotestis on other side, or there can be a mosaic of 45X and 46XY, which is the most common cause of chromosomal DSD, which is mixed gonadal dysgenesis. So second evaluation after chromosomal sex evaluation is the gonadal sex. Gonadal means which gonads are present in that individual. So by definition and by a golden thumb rule, if a gonad is palpable in the labioskrotal fold or in the pelvic area, this has to be a testis. So any newborn child or any individual born with a hypospadias, ambiguous genitalia or atypical genitalia, but bilateral or unilateral palpable gonads in the fold, this has to be testis. But if this is not available, if this is not palpable, then we may have to look at the other investigations like ultrasound, MRI, and sometimes laparoscopy and sometimes open laparotomy to see which gonad is present to further diagnose the condition. So this is an example. So chromosomal sex is the form as fertilization, that is XX or XY. Similar development till 6 weeks. At the time of 6 weeks, depending upon the chromosomal sex, there is a development of gonads. So, and this further leads to development of internal genitalia. So if there is a testis, two Leydig and Sertoli cells, there is a development of Wolffian structures, and there is a regression of Mullerian structure, and there is a formation of male internal genitalia. But if the testis is non-functional or the SRY gene is non-functional, by default development is to the ovary, where there is no testosterone, there is no Leydig cells, there is no Sertoli cells, so there is a regression of Wolffian duct, and there is development of Mullerian duct. But between two spectrum, there lies where something is gone wrong. If the testis is not very much functional, or testosterone is not active, or SRY gene is defective, then there is an ambiguity. So even if the chromosomal sex is 46XX or 46XY, there is a gonad formation, testis or ovaries, still there can be ambiguity of genitalia. And these various genes which are located on various chromosomes, they can be responsible. So if your chromosomal sex is normal, you have determined the gonads, then you have to see so many genes and many more genes to look at the causes. And to look at those causes, a next generation sequencing based panel or exome sequencing becomes the test of choice. And we will reiterate in future slide again and again. Then coming on to the external genitalia, the important thing to note is external genitalia is influenced by all androgenic and all estrogenic hormones. It's just not testis or ovary. This is adrenal hormones as well. So look at this condition, which is 46XY DSD, where chromosomal sex is 46XY. Testis is present as gonad, so gonadal sex is okay. Testosterone is formed properly, so there are Wolffian structures and there are no Mullerian structure, but still the action of testosterone on the external genitalia is missing. And this is the most common cause of a 46XY DSD, basically testosterone synthesis defect, receptor defect, or androgen sensitivity. So even if there is an XY, there is a normal SRY, there are normal testes, there are normal functioning testosterone, still the external genitalia may be feminized. And depending upon the degree of this defect, this can be a complete form or this can be an incomplete form, leading from complete females to the ambiguous. On the other hand, if there chromosomal sex is XX, ovaries are there are internal genitalia is compatible with the female architecture, but during pregnancy at the time external genitalia was getting formed, that is exposed to the maternal virilization, drug intake, or the hormones, or the tumor, or a genetic defect called as aromatase deficiency, and the most common cause congenital adrenal hyperplasia. So there are, even if the chromosomal sex, gonadal sex, internal genitalia are female type, because of the effect of the androgens during development, those XX females can have a masculinized external genitalia, and that becomes the most common cause of an 46XX presenting with an ambiguous genitalia. So we have seen chromosomal sex, and the type of test is stereotype. Rapid test is FISH, and some people do the PCR testing for SRY gene to quickly see whether an SRY gene is functional or not. Then you have to see the gonadal sex by clinical examination, radiological, laparoscopic, and so on. Internal genitalia also falls in the same category of set of investigation: clinical examination, radiology, and laparoscopy. And this is the quick revision. If by default there is an ovary, Wolffian regression, Mullerian development. If there's an XY, testis, SRY, leads to Wolffian development and Mullerian regression. And if there is a deviation, non-functioning or incompletely functioning, SRY absent, then there will be a partially complete female, or there will be an ambiguity. So coming on to the functional status of gonads, that is an endocrinological workup, whether the gonads are producing functional hormone or not. And the investigation depends upon the age of presentation, and typically they are these: FSH, LH, testosterone, and beta-HCG stimulation tests. They typically tell you the differentiation between the gonad dysgenesis, if the gonads are functioning or not. And if the gonads are functioning, hormones are being produced, they are able to act or not. And a lot of these depends upon the age of presentation as well. And in this endocrinological workup, the workup for congenital adrenal hyperplasia also comes up, and we will talk about in the next slide. And then there is a phenotypic sex, that the clinical evaluation, the evolution of the phenotype at puberty and fertility preservation. And again, it depends upon the age of presentation and so on. So coming on to DSD classification, and as I have been telling, it starts from the karyotype. So every word, every part of the DSD starts from karyotype. If it is a chromosomal, if you find something abnormal in chromosome, like a mosaic or a mixed congenital dysgenesis, your diagnosis is confirmed. You don't have to go for any other genetic test. Coming on to the gonadal sex, if your chromosomal sex is normal, but still the child is presenting with the atypical genitalia, then it all depends upon the other test investigation. This is 46XX DSD. The most important cause is the congenital adrenal hyperplasia, for which there are specific testing. If this is an XY DSD, the choice of test is usually the large NGS panel. They are exome sequencing. And there are some other rare cause of ambiguity where the atypical genitalia are part of the spectrum, like cloacal exostrophy, MRKH syndrome, vaginal atresia, Prader-Willi syndrome, Smith-Lemli-Opitz syndrome, where you will see a systemic features in the child as well. So DSD presentation. DSD can present from prenatal to adulthood. Prenatal, there can be a discrepancy between the chromosomal sex and phenotypic sex, but difficult situation in India because of the PCPNDT rules and regulation. One of the most important present is a newborn or the childhood with atypical genitalia. There can be undescended testes, hypospadias, clitoromegaly, and the range of ambiguity in the presentation of genitalia. There, during childhood or during puberty, there can be an absence of puberty, underdevelopment, like amenorrhea. We have heard from Dr. Veronica about it. Or there can be an opposite development from the sex of rearing. Imagine an individual who has been raised as a boy till puberty, and at the puberty, he starts having breast development. And that is a very typical of 46XY DST, testicular insensitivity syndrome. And these poses a very serious ethical, moral, and the clinical dilemma in front of family and the doctors. Sometimes it comes up with a fertility workup, and sometimes they present with the gonadal cancers as well. So how do you approach? As a clinician, we always start with the history. So consanguinity, similar history in the family, puberty problem, reproductive issues. In fact, we have seen a couple of families where two siblings are having the same genetic disorders, androgen insensitivity syndrome. One is reared as male and second is reared as female. So there can be history of neonatal death. And if something is like this present, we have to think of CAH strongly in those situations. There has to be a specific genetic test to be ordered for those situations. The history of pregnancy, virilization, androgen exposure, any hormone supplementation if the individual is presenting late, any previous surgery in the past, so on and so forth. Then you come to the examination. So in genitalia, Indian Society of Pediatric Surgery has defined some guidelines, what points has to be given in genitalia. There has to be a systemic examination, and if the individual is older, we have to look for secondary sexual characteristics, breast examination, so on and so forth. This is a typical chart which we used to learn in our learning days. So if any child is presenting with the ambiguous genitalia, the first thing we have to palpate the gonads, if this is present or absent. But as you know, no clinical disease follow a chart. So everything comes as a synthesis by looking at the every evidence together. But look at the left side of the column. So what you have to see, at least clinically at the first go. So gonads, palpable or not. If you are able to see mullerian structure in ultrasound or MRI, 17-hydroxyprogesterone, if it increase, it is a short diagnosis of CAH, and then it starts with the karyotype. FISH can be done for a rapid diagnosis. So again, karyotype is must. Second is the gonadal examination, palpable or not, an ultrasound, a functional assay of hormone, endocrinological workup, but 17-OHP is the must to rule in or to rule out CAH. So if your diagnosis, clinical diagnosis is more towards CAH, it has to be a targeted assay for CAH. If it is non-CAH, if it is 46XY-DSD, NGS panel or exomes are the test of choice, and which we have to choose carefully after a probable diagnosis. And other things, if this is a malformation, so we have to order the range of tests based on karyotype, microarray, next generation sequencing, so on and so forth. So beyond genetics, we have to diagnose and we have to deal with several situations. And these are the issues which we have to deal with in every individual with DSD. One is the gender assignment at birth. We have to decide sex of rearing. There are emergency concerns in CAH. Child may die unexplained. There can be a history of neonatal deaths. Other organ malformations like Dennis-Trash syndrome, you can have renal dysfunction, nephroblastoma in early childhood. There are long-term psychological concerns, and these individuals have to be followed their lifetime. Hormonal supplementation, planned puberty initiation, hormone replacement therapy, fertility preservation, surgeries, reconstructive surgeries, removal. So this is a long process, and no single person can do it alone. So there is something like multidisciplinary committee. And these all management has to be done in taking care of cultural, religious beliefs, psychological impact. So in every state, there is a local multidisciplinary committee, and anyone who is dealing with these cases with atypical genitalia or changing the sex of rearing or sex assignment, they have to inform to them, and they have to take care of those clinical as well as familial issue. There are emergencies, as I said, gender assignment is an emergency at the birth. There can be metabolic crisis, and as I said, we have to plan multidisciplinary care from the beginning. So there are certain rough guidelines. How do we assign gender? Basically, this is based on chromosomal sex, phenotypical sex, gonadal sex, the projected development, puberty development, the type of surgery which might be required, the family religious belief, the sexual potential, and there has to be a team for it. And all these can happen if we provide the psychosocial and proper counseling to the families. So these are general guidelines. So if this is an XX, and the most common cause is CAH, they present with clitoromegaly. They are mostly reared as female. If this is an XY, palpable gonads, even if there is a severe hypospadias, they are mostly reared as males because there are gender dysphoria is less. But if there's a complete reversal, even this in 46XY, they are reared as female with the testis removal later on in life. But difficult in the cases of where ambiguity is too much and where projection of the further development or puberty development cannot be made. And that is mixed gonadal dysgenesis, partial androgen insensitivity syndrome, and ovotesticular DST. And as I said, it has to be given in consultation with local multidisciplinary committee or SMDC, state multidisciplinary committee, or a national level apex multidisciplinary committee. And there is a team of pediatric surgeon, pediatric endocrinologists, and child psychologists and psychiatrists, and geneticists and medical social workers available. And if the family is going for and opting for any surgery and the child is more than 12 years, child's verbal or written consent is required. Some clue to your clinical, any sick child with atypical genitalia, CAH should be considered and treated and tested for. These are typical glucose, electrolyte, or metabolic disturbances. Steroid supplementation can make the child life very easy, though long-term follow-up are required. And of course, pediatric endocrinologist has to be involved from the beginning. In the surgery, there are 3 types of surgeries. One is the reconstructive surgery. Reconstructive surgery is usually deferred by 12 years of age so that child can provide verbal consent. Then there is a gonadectomy or excisional biopsy due to risk or development of gonadal cancer, and I will talk about it. And if there are emergency situations like recurrent urine infections or urosepsis due to anatomical obstruction, these are the 3 indications where the surgeries in DSTs are indicated. Puberty initiation and maintenance is a complex issue because we have to replicate normal puberty maturation, optimal bone mineral density, psychosocial, psychosexual development. Sex of rearing might be different. There can be puberty changes. Gonad surgery might be required. Reconstructive surgery might be required. So again, the role of pediatric endocrinologist and psychosocial worker cannot be stressed upon more than this. There are several cases when we change a gender change at puberty, as I have spoken about androgen insensitivity. And at that point of time, those local and state level multidisciplinary committee has to be involved and child's verbal or written consent has to be taken. So if fertility preservation. So fertility preservation also is a multitask procedure. We have to see the functional status of gonads, what kind of reconstructive surgery has been done, if we can do the fertility preservation, especially in the cases of Turner and Klinefelter syndrome, where we can offer an early gamete presentation. If there was a dysgenetic gonad or risk of malignancy and gonads have been involved or not. So this is really a complex issue and has to be dealt with a complex team of obstetrician, endocrinologists, geneticists, and ART experts, so on and so forth. Coming on to a slide about risk of malignancy. So if a gonad is dysgenetic, non-functional, especially in the presence of a Y chromosome, then there can be a risk of malignancy, especially gonadoblastoma. This risk is as high to 50 to 60% when there is a WT1 mutation present, where other kidney abnormalities can also be there. It is also high in the partial androgen insensitivity syndrome, and the testis is not palpable in the scrotum. And it can be 15 to 20% intermediary when there is a mixed gonadal dysgenesis, but testis is dysgenetic is a high risk for malignancies, and they have to be followed up at routine intermediate interval. If there's a high risk, the surgery has to be done in early childhood. If there is an intermediate risk, then around puberty and adulthood. If there is a low risk, they can be typically followed up at a regular interval. If you have a family with a history of previous child with DST, so again, we start with the history, consanguinity, family history, clinical examination, crisis, emergency episode. Do you have a newborn screening test available which shows a raised 17-OHP, clinical examination note, investigations, genetic and non-genetic has been done. If the child is not alive and you have limited information of couple, we start with karyotype of the couple, can still be done. but diagnostic yield is limited because we are not expecting anything in the parents regarding chromosomes. If you have a 46XX DST, or there is a history of,
Ma'am, your time
517
is up.
OHP. Okay, should I go on for
Yeah,
next three more slides?
Yeah,
Okay.
yeah.
Okay. So if you have 46XX or raised 17 OHP, history of neonatal death, CAH targeted assay. If there is anything else, then consider whole exome sequencing of both the parents. But the diagnostic yield may vary from 15 to 30%. So that pre-test counseling should always go to the family, and it should be done preferably with a consultation with the geneticist. And as my previous speakers have been emphasizing, it should be combined with pre-test counseling and post-test counseling. An important thing is prenatal invasive test is not helpful if a definite diagnosis is not established or there are uncertain findings. A couple of slides about CYP21A2, which is the most common cause of CAH in 46XX DST. Exome sequencing, microarray, karyotype will not pick up these disorders, and there is a specific combination of tests, which is MLPA and targeted NGS for CYP21A2, and which is followed by a very complicated analysis. So if you have diagnosis of CAH, please consult your geneticist fellow to assist with you the type of testing and the analysis. So this is, we have already discussed, XX, high 17 OHP, electrolyte imbalance, sick neonate with atypical genitalia, previous history of neonatal death, CAH is a strong possibility. Second most common is XYDSD, hypospadias, bilateral palpable gonads. The most common is testicular synthesis or the receptor defect. I think I will end here. Thank you so much.
That was a wonderful presentation. The difficult topic had been simplified with very clear algorithm. So it was really interesting. And one interesting fact is we love panoramic view as endoscopic surgeon. That is also seen in genetics and fetal medicine. That was really interesting. Thank you, Dr. Meenal. And once again, I thank all the organizers for inviting me as a chairperson. Thank you.
Thank you so much, ma'am. Now we finally move on to our last talk for today before we have our quiz, the MCQ that is. I would invite Dr. Shraddha Agarwal ma'am to introduce our next speaker.
Thank you so much for making me a part of this course, and thank you Dr. Parag sir, Dr. Sadhana Gupta ma'am, and Dr. Pooja for inviting me for this session. And now I would like to introduce Dr. Manjeet Mehta. Ma'am is medical genetist for over 34 years, and she is director of Life Genomics Laboratory and Research Center, Mumbai. She has international trainings from various places, and she owns the awards like Champions of SR Award, and she has multiple publications. And the topic today she is going to present is PGT, which is very good topic, and we need to know much more about PGT-A, PGT-SR, and which we actually need, because when we get the patients for RPL, we don't know whether to send for PGT-A or SR, and various doubts are there. So ma'am, please, I welcome you for this talk, and we eagerly wait for your insight in this topic. Thank you.
Thank you very much, Dr. Shraddha, for the kind words of introduction. I'm amazed at the collection of topics and the conducting of this entire course that has been so beautifully done. Dr. Sita, Dr. Chinmay, Dr. Pooja, hats off to you all, And to the audience who is still alert and attending, even at this time. It's like a whole bandara of knowledge, that you all are gaining. So it's been a very really interesting 3 days, and as we come to the end, I'll try to make it really short so that people don't start leaving. So, Chair Madam has given a very nice opening for my talk on PGT. And okay, so fertilization, natural conception are something which we have been seeing over the years, and the processes that are included in that. When you go in for an assisted, after the fertilization and the various cell division stages, we go to embryo implantation and pregnancy is established. In an assisted reproduction, it starts off with an ovulation induction, and then there's an oocyte retrieval, and fertilization is either through insemination or ICSI. This embryo is transferred. Before all that, a biopsy is conducted, and which is what I'm going to talk about. And then it needs to be followed up with the prenatal testing. The success of IVF is somehow, by itself been really very low, and it's just around 20 to 30% of IVF cycles, which result in a live birth. And many times people are transferring multiple embryos. So causes could be anything, because the way we are assessing the embryos before transfer is a morphological characteristics or a morphological assessment that we are looking at, and it doesn't have a good correlation with the genetic content. Morphologically, most of the embryos will appear normal, but then we need to know what their genotype comprises of. So what's the solution to that? It is pre-implantation genetic testing. So just as in this IVF process, there is this additional step which is added, where you may remove a few cells at the trophectoderm stage and you test it. And then after that, the embryo transfer is done. So to define it, it is the biopsy of a single cell per embryo, followed by the genetic diagnosis. And this has been around since like 1990. Indications for this would include recurrent implantation failures or recurrent miscarriages. If there is a child affected with a genetic disease and you want to rule that out, if there's a family condition, and if one of the parents is a carrier of a balanced translocation. So the various terminologies I'll familiarize you with. PGT-SR is for structural rearrangements, where, as I said, if one of the parents is a carrier of a balanced translocation. There's PGT-A, which is PGT for aneuploidies, to rule out aneuploidies of, like now, it's all the chromosomes. And PGT-M is if there is a for mutation or monogenic conditions, if there is a non-familial condition. So PGT-A involves screening for aneuploidies to rule out the monosomies and trisomies of all the chromosomes. PGT-SR, the parents are themselves normal, they are carriers because their entire genetic material is complete, although it is like shuffled around a bit. But because of that, the gametes would have some imbalanced material. PGT-M is for monogenic conditions. It could be autosomal recessive, like beta thal, CFTR. It could be autosomal dominant conditions. And there's a specific gene or a condition which you are looking out for. PGT-HLA is also done. And if there is an elder sibling who needs a bone marrow or an organ transplant, and we need an HLA compatible second child. So which method is to be used for this pre-implantation diagnosis? I know you all have been bombarded with a lot of genetic technologies and things like that. But then, it is the era of genomics, and there are a whole lot of various technologies. Each of them have their own limitations, their own applications, their own turnaround time, their own preferred methods for certain conditions. And today, genetics has entered mainstream medicine, and all the practicing clinicians are getting more and more involved. And it's good if we understand the science. It will help us better in our clinical practice. I understand it is people are busy in their practice. Taking family history is cumbersome.
it's sometimes intruding into their privacy and things like that. But then, I mean, genetics is here; it's here to stay, and it's they say it's going to be as common as biochemical tests very soon in the future. Coming to the first thing, which is fish. In fish, the biopsy sample is taken on a slide. That slide is processed and some stains and counter stains and stuff, and it is examined under the fluorescent microscope. So we look out for 2 signals, 3 signals, and we have different colored fluorescent probes for different chromosomes. Fish is target specific. We need to apply those probes for those chromosomes which we are wanting to look out for. It is operator dependent. It is a very low sensitivity method, and now it has very limited applications. Coming to PGTM, it is in a recessive condition. One of the parents are carriers. We first thing first, we need to know the parents' mutation testing. It's not enough to have the HPLC report and to say, yeah, she is a carrier or she's a trait. We need to have their mutation testing. We need to test the other partner. So if the other partner is not a trait, you don't even need to do the test, any kind of a pre-implantation or a prenatal test. That is one. The other one is for autosomal dominant conditions. So there also we can do PGTM, which is for monogenic disorders. There, those cells that we biopsy are collected in a tube with a lysate, and then there's a whole lot of processes that go on. And then there are many downstream methods that we can apply on this. I'll come to those methods. This can be done, as I said, for any condition. It could be autosomal recessive, it could be autosomal dominant. We need to establish the parent's genotype. That is really very important before we try to test on the pre-implantation testing. Now, when you're looking out for a mutation in a gene, there are different PCR methods for different genes also. So if it is something like a thalassemia or a cystic fibrosis gene, which is a point mutation, you can do it by a PCR RFIP or even by a Sanger sequencing. There is something known as these triplet repeat disorders. So Huntington's disease has a CGG repeats. Fragile X has CGG repeats. Huntington disease has CAG repeats. Spinocerebellar ataxia. They have these triplets which are repeated 200, 500 times. There we have to do a short PCR or a triplet primed PCR. Then there are the deletion duplication conditions, Duchenne muscular dystrophies, SMAs. There we need to do an MLPA. So these are all modifications of PCR, you may call them, but different tests for different indications. And they are done by sequencing. They are done on a rotor gene, on a real-time PCR machine, and okay, now coming to chromosomal microarrays. So chromosomal microarrays, you have a general look at the entire genome like you do in karyotyping actually, but this is much, much more sensitive than that. It has a higher resolution. It is a DNA-based technique because you extract the DNA from the sample. So you don't need to culture it and all like we do it in the routine karyotyping. And you can pick up even submicroscopic deletions, duplications, any copy number variations, which cannot be picked up by karyotyping. Of course, you can't do karyotyping on a pre-implantation tissue. So chromosomal microarray, is also known as molecular cytogenetics. So this is just to give you a little bit of a context. The image you see to the left is a routine karyotype which we've been seeing since the last 40, 50 years. You can compare it to this so-called blurred image, you can make out it's a water lily and you can make out there are some leaves in the background, but the sharpness and the resolution is the difference that you get in a microarray. So if you see at the bottom that chromosome 13, if there's a large chunk which is deleted, you may be able to pick it up on a karyotyping. But if it is a small part which is deleted, it can only be picked up by a microarray. So this is the beauty of microarray. Then when we talk about sequencing, so there is Sanger sequencing and there is next generation sequencing or NGS. So Sanger sequencing is used when there is a single gene or if there is a fragment of a gene, if there is a small gene, and when you want to look at multiple genes and multiple targets, like if you want to do aneuploidies of all the 25 chromosomes, then NGS is the method of choice. Now coming to PGT-SR or structural rearrangement. So in this, as I said, one or both the parents has a balanced translocation, which is a structural rearrangement in the chromosome. And then there is a chance of having a pregnancy with an unbalanced structural abnormality. And, it reduces the risk of having a pregnancy by doing this PGT-SR. So this is a typical report, when the parents' blood karyotyping is done. So this is one of the partners having normal 46, but then in that there is a translocation between two chromosomes. So if a person is known to have a balanced translocation, they have 75% chance in every conception, to have either an abnormal child or a missed abortion. And because in the inheritance, there may be some imbalanced material in the gamete cells. So, yeah, I think this is a repeat. Now, the way translocations can be detected using fish, we get these probes designed. And as I said, this is what a translocation looks like. There are two chromosomes, they both break at some point, and there is an exchange of the material. And the entire material is complete. But at the time of inheritance, when they separate from their sister alleles, that time is a time when the gametes can have an imbalanced material. So the probes are designed which are specific to these breakpoints. And then in the pre-implantation sample, we look at it that way. So when you can see that green and orange probe are together, means that is the balanced translocation which is there in that cell. Coming to PGT-HLA. So this, as I said, is to select an embryo that is a genetic match for an existing sibling who requires a stem cell or a bone marrow transplant. And if there is a sick child in the family with a serious blood disorder, either thal, sickle, aplastic anemia, leukemia, Fanconi's, or some of these immunodeficiencies, we test for the HLA compatibility to match the affected sibling, and we create a savior sibling who can donate their cord blood or bone marrow or something to the affected brother or sister. It is very important that there has to be a constant back and forth between the IVF lab and the genetic lab, because and the clinician, of course, the clinician and the IVF lab are usually located at the same place. Some of them may be having an in-house genetic lab, some of them are sending it to a standalone genetic lab. So, concurring about exactly which technology, what needs to be tested for the genetic lab, giving them the feedback. And all of this has to be a constant dialogue between the two of them. PGT comes with its own package of risk. There could be an embryo damage because ultimately the biopsy is an invasive procedure. There could be a misdiagnosis. So theoretically, the accuracy is around, for translocation is around 90%. There could be a false negative. There is a chance there'll be no results. Then there is a chance there may be mosaicism, which may develop later, which may be present initially. IVF has its risk, embryo damage has its risk, not achieving pregnancy is another aspect which we should consider. After the test results, there may not be any normal embryos available for transfer. And PGT is expensive, labor intensive. You need a really specialized lab to be able to do it. Also, PGT can detect only specific genetic disease in an embryo. It cannot detect all genetic disorders. And even after that, it cannot guarantee that the fetus will not have an unrelated birth defect with some other condition. So that is the reason why, like all the previous speakers have also emphasized the importance of pre-test and post-test counseling. All this needs to be explained to them. Can mistakes happen? Anywhere they can. Sometimes it's about the biology. Sometimes, there's a mosaic tissue in the blastomere. What you pick up is representative. It may be just belonging to one part of it. And in cell division, both the cell lines, they divide. It could be something, human errors like mislabeling, misidentification. I mean, this apply to all different testing technologies. Wrong embryo transfer, incorrect probes, or there could be something technical. The primer could fail, the probe could fail, there could be some contamination, maternal, paternal, operator, anyone. And there could be something which is intrinsic in the embryo itself, like a mosaicism. It's also called as allele dropout. In the laboratory, we get this at times. You're just not able to pick it up. Or there could be a uniparental disomy where both the alleles come from one parent. So all this also we need to consider. Benefits of PGD are quite apparent. It increases the implantation success rate. It rules out the condition which you're looking out for. There is a reduction in the chance of having a child with aneuploidy once you have done the aneuploidy testing. It reduces the possibility of having to choose to terminate a pregnancy following a diagnosis of a probable disorder, and reduction in the pregnancy losses. A very important point is for a prenatal testing, a screening or testing to be done after the pre-implantation genetic testing. So, as we all know that PGT cannot identify all the genetic abnormalities in a fetus. So at that time only, it's good if you can counsel them about the prenatal genetic screening or the testing, and tell them about it. Even if there's a negative PGT result, it is not a guarantee of a newborn without any genetic abnormalities. False positives, false negative results can occur with a PGT. Therefore, prenatal diagnostic testing, ideally through CVS or amnio, should be offered. Now, in case some people are apprehensive because of the associated risk of miscarriage, at least we could give them a prenatal screening, dual quad, NT, and IPT. And they should be also informed that these are ultimately screening methods. They do have the limitations, things like that. So, to develop, in conclusion, I would just like to say that the development of PGD is one of the most exciting and important milestones, that we have had in the history of ART. Because for couples who are at a risk of having a child with either a monogenic condition or a chromosomal abnormality, it represents a major scientific advance. Last bit that I want to talk about is non-invasive PGT. You would have heard of this. And what happens is a drop of the culture medium in which the embryo has developed, that provides a chromosomal information from the embryo. So NIPGT or non-invasive PGT is a novel approach to the genetic analysis of embryos. And the premise is that the genetic material in that spent embryo culture corresponds to the genetic material in the embryo cells itself. And this has also emerged from discovery of embryonic DNA in the spent culture medium. We took a biopsy, we tested that. I mean, there have been studies on this. And then we took the culture medium around it and we tested that. And there was concurrent results. And the premise is that, liquid biopsy and cell-free DNA, nucleic acid analysis, it's already well established in many fields of medicine. See, what is NIPT? It is nothing but circulating fetal cells in the maternal blood. So they are cell-free DNA in the maternal circulation. For malignancies, we are doing a lot of liquid biopsies rather than exposing them to either an invasive method or a CT or a PET. We just take the blood, and these tumor cells are also circulating in the blood, circulating cell-free DNA is there. So using that same logic, very soon we will have the answers to this, that is there embryonic cell-free DNA which is detectable in the spent culture media? Does it represent the chromosome content of the embryo? There are a lot of people who are doing it. It has not yet been permitted for clinical use, but that day is soon going to be here. Thank you very much.
Thank you so much, ma'am. That has been quite quite a wonderful talk.
So Sita ma'am, Chinmay ma'am, amazing work. Pooja,
No, thank
amazing
you,
work
but
that
all
you all
of
have
you did
done.
the amazing work. We were just in the background listening to all the talks.
This is really,
But
really superb.
the talks were wonderful. I mean, honestly, it feels sad
All
more
of
than
them, yeah, I've attended quite a few of them. They've all been really wonderful. And we've got a very good participation.
yes, yes.
Yeah, so
All
I'll allow you to
Dr.
proceed.
Sita's brainchild. Oh, she's muted. That is not fair. Wait.
Please allow her to unmute it.
Gauri, please co-host Sita ma'am.
Thank
Yeah,
you.
yeah.
Thank you so much. Now I'm finally in. I've been trying for a long time. Thank you, Dr. Manjeet, and all the speakers. Today was very different. And as Dr. Pooja was saying yesterday, we don't know much about gynae, but we've learned a lot about amenorrhea. Inherited cancers was very nice. And Dr. Narendra Malhotra sir's topic and PGT. So thank you all once again. I think it's time for the link to be set. Everyone's waiting to give the MCQ.
Yeah, today's link should be very interesting.
Ma'am, shall I
Gauri,
post
please
the link?
post the link in
Yeah,
chat.
can we
Yeah,
have the link,
Yeah,
Sita
sure.
ma'am and Chinmay
Yes.
ma'am?
Anjit?
And put on the QR code also.
Yeah, please post the test link for MCQ and the QR code in the chat box. All of you are requested to submit within the stipulated time. There will be an warning bell 1 minute prior to submission. No late submissions will be allowed. Please check your internet connections and all the best.
Someone is asking why QR code. So if you want to screen it on your QR code also, you can reach that link. If you want to go directly by your link on your system, that is also acceptable.
I'm waiting to start the Sampurna in Kolkata. So Again, looks like it was easy today. Most of them have done.
Yeah, I was about to say that. Looks like it was easy.
All the talks will be uploaded on the ICOG website, but not immediately, a bit later. So please keep checking the Foxy ICOG website for updates. Thank you. Dr. Mani, we have taken note of your name and mail, so we will consider that. Thank you, Sri Lakshmi. Thank you. Vicky Porisse. So 2 minutes left for the MCQs.
Last 30 seconds, requesting everybody to please submit on time. Once the timer switches off, your responses will not be accepted. So congratulations everybody for having completed an exhaustive but a very, very knowledgeable marathon and academic feast on genetics. And yes, we did keep the day 3 MCQs slightly easier than day 1 and day 2 because it's a relatively untouched and new topic, gynecology and genetics. So in fact, we tried to keep it easy. Let's see now, let's discuss the answers.
Pooja, before you answer the questions, can I just interrupt?
Sure,
Because
sir.
I need to attend the POG's meeting. I thought I'll appreciate the work done by 3 of you. So thank you, Sita. Thank you, Chinmay. Thank you, Pooja, for being very, very sincere and committed conveners. Similarly, we had very young, enthusiastic coordinators. Aarti, thank you for being part of it. And of course, Navya and Kanan, who were there on the first, second, and first day, respectively. This is something, this is an area which is new to many of us. So when the first day was going on, and I had a discussion with Sarita, and both of us agreed that it was, all the lectures were bouncers at times. So we really have to, study hard and understand, because all these things are going to change our clinical practice, and of course, it will have a good impact on the outcomes also. And before I sign off, I just wanted to let everyone know that on 8th and 9th, the Foxy ICOG is tying up with the RCOG for an official Part 3 MRCOG course. So those candidates who are interested, we still have some seats available in Mumbai. Do get in touch with the ICOG office. And the next course for certificate course for the month of April will be on the 23rd, 24th, and 25th of April, and this will be on infertility and assisted reproduction. So we are tying up with the Indian Society for Assisted Reproduction for this particular course, and we look forward to seeing you all again. So I thank all the delegates who have been a part of the program today, and hope to see you soon. And of course, one more announcement that from next month, we are starting a new series called Harmony, and it is all about very basics of reproductive endocrinology, especially meant for postgraduate students, but those consultants who are interested in learning reproductive endocrinology, please join these courses. Just watch this space for advertisement from ICOG. So thank you very much, and I hope to see you again sometime next month. Thank you.
Thank you, sir. Thank you for the opportunity, actually.
Yeah, thank you. Thank you so much for the opportunity.
So, Miss Gauri or Nilima Madam, whoever's here, could you please post today's
Yes.
MCQs?
Yeah, Gauri.
No, these are not today's MCQs. This is day 2.
Just a minute now.
Sure, sure. So, in the meanwhile, any questions in the chat box? I think today's lectures were crystal clear, very, very simplified.
Clear messages.
Beautiful. Yes, very nice.
A few questions.
Yeah, so information on all the courses will be on the ICOG website. The team ICOG will post the office number shortly. Okay, no, Dr. Jyotsna, the answers are yet to be discussed. We are just starting now. Okay, so the first question here. Which of the following is not a genetic cause of female fertility? So yes, we know that BRCA1 mutation increases the risk of breast and ovarian cancer, and it does not cause infertility, whereas all the 3 others, Turner's, Fragile X, and androgen insensitivity syndrome, are causes for infertility. Which of the following chromosomal abnormalities is most commonly associated with male infertility? So Turner syndrome, Turners are females. So the question here asks male infertility. So the answer is Klinefelter syndrome. Down syndrome, yes, they have reduced fertility, but it's not the commonest chromosomal abnormality with associated with infertility. Whereas Patau syndrome, we know, is a lethal abnormality, and never ever will a Patau live up to the age of reproductive age to call that baby, the child, fertile or infertile. Which of the following conditions is associated with premature ovarian failure? The answer is Fragile X premutation. So premature ovarian failure cannot happen in Klinefelters because they are males. Cystic fibrosis, it can affect males and cause subfertility or infertility because there could be a congenital absence of vas difference. But the question here says premature ovarian failure, and therefore the answer is Fragile X premutation. Which assisted reproductive technology is commonly recommended for male infertility due to genetic causes such as Y chromosome microdeletions? Now we've heard today in lectures that Y chromosome microdeletions can cause oligozoospermia, azoospermia, and abnormal morphology of the sperms, and ICSI, in fact, much better than even IVF, and absolutely not IUI and clomiphene citrate on ovulation induction. So ICSI means intracytoplasmic sperm injection, where you can actually choose a healthy looking sperm and inject a single sperm into an oocyte and form a baby. So you are actually doing sperm selection and therefore selecting the healthier sperms, improving the chances of a better pregnancy outcome. So the answer is ICSI. What is the main purpose of a pre-implantation genetic testing? It is to identify genetic abnormalities in embryos before implantation. So yes, it is not genetic disorders in newborns, that is newborn screening. It is not to treat inherited genetic diseases in adults, and it is definitely not to modify genes in embryos, but it is to identify genetic abnormalities in embryos before implantation. Which of the following is not a type of PGT? We just recently heard from Madam that the three modes of PGT are PGT-A for chromosomal abnormalities, PGT-M for monogenic disorders or single gene defects, and PGT-SR for structural chromosomal rearrangements, whereas there is not an entity that is identified specifically as a type of PGT known as developmental defects, and therefore that is the answer. What is the method used to obtain cells from an embryo for PGT? Now this was very, very simple. It is known as embryo biopsy. Can you please go on to the next slide, Gauri? The next one, please. Okay. Which technology is commonly used for genetic analysis in PGT? Again, a very, very simple one. It is not MRI, not X-ray, not ultrasound, but a next generation sequencing, NGS as we call it. Which of the following is true regarding PGT and embryo viability? So the second one is the answer, which says that embryo biopsy during PGT. So an embryo biopsy, like we heard, is usually done in the blastocyst phase. And sometimes it may slightly reduce the implantation rates. But the A, C, and D are not incorrect. So obviously making the B as the correct one. A says PGT guarantees that an embryo will implant successfully. No, it does not. It does improve chances of success, but it does not guarantee that the embryo will implant. PGT is performed after the embryo is implanted. No, PGT is performed before the embryo is implanted. All tested embryos are always suitable for implantation? No. The whole purpose of doing a PGT is to select the genetically normal embryos, and therefore the ones that are genetically proven abnormal are not included for the embryo transfer. Hence the answer B is correct. What are the risk factors of RPL? They include all the below except. So of course, having a previous live birth in fact reduces the chances of RPL, and all others are associated with RPL. So advanced maternal age, advanced paternal age, consanguinity, we all know that these are risk factors for RPL. Which of the following gene is not associated with cancer? So we just heard in a very elaborate lecture by Madam that proto-oncogenes, when mutated, become oncogenes. So these are associated with cancer. DNA repair gene. So any defect in the DNA repair gene will inhibit a proper repair of an abnormal gene and lead to cancer. Whereas a tumor suppressor gene is a gene that brings cell growth in control. So if there is an abnormality in the tumor suppressor gene, it leads to cancer. Whereas the housekeeping gene is a gene that is responsible for basic cellular functions, and therefore the housekeeping gene is the answer for the 11th one. The 12th one, we just discussed this as a part of the initial MCQs as well. Which gene mutation is commonly associated with congenital absence of vas difference and male infertility? So it is the cystic fibrosis gene. Okay, so the answer to the 12th one is A. Can we have the next slide, please? Gauri, can we have the third slide? Yeah. What is the most common cause for spontaneous abortion in the first trimester? So we are aware that 50 to 70% of the abortions in the first trimester before 12 weeks are because of aneuploidies or chromosomal abnormalities. In fact, we call it as the nature's way of not allowing the abnormal or aneuploidy embryos to go ahead. So the answer is chromosomal abnormalities, of which chromosome 16 is one of the commonest. Criteria for APLA syndrome, we are aware since our MBBS days, the same criteria have been going on. There are clinical criteria and lab criteria. Essentially, one of each is a prerequisite to define APLA. The ones mentioned here are all clinical criteria. A, C and D are correct. Why B is not correct? Because it says one or more morphologically abnormal fetal losses. So as soon as there is a morphologically abnormal fetal loss, it means that the reason is not APLA, there is a genetic cause behind it. And therefore B is the wrong one. The answer, the correct sentence would have been one or more morphologically normal fetal losses at or above 10 weeks of gestation. Hence the answer is B. 15th one, 34-year-old lady underwent genetic analysis for her products of conception, which showed an unbalanced gamete. Which are the tests of choice for detecting unbalanced translocation carrier? I think in all the talks almost today, they have emphasized that how many ever new tests in genetics come up on the block, karyotype is the only one that will be able to detect a balanced translocation carrier. So yes, karyotype is the answer because it tells us about the chromosomal structure and the arrangement at its best. 16th one, a 32-year-old para-0 living 0 previous 3 abortions presented with 1 week overdue and UPT positive. She was investigated for recurrent pregnancy loss and was diagnosed to have APLA positive. How do we manage? So this is the protocol. In fact, one of the most evidence-based indication for using low molecular weight heparin in pregnancy is APLA positive. So as soon as she misses her periods and UPT is positive, we start her on aspirin and LMWH. Unlike is thought in a lot of in a lot of protocols in various institutions, we do not wait for the cardiac activity to appear for starting LMWH. But because there could be a thrombosis that could trigger off a missed abortion before you wait to start the LMWH, you can never ever guess what date and time the fetal cardiac activity is going to come. So as a protocol, as soon as UPT is positive, you put her on aspirin and LMWH immediately. What is the mode of inheritance in hereditary breast and ovarian cancer? It is autosomal dominant. We've heard lots about this. What genetic test would you suggest based on the above pedigree? So we see that there is a history of ovarian cancer, breast cancer, and we see we are doing BRCA1. One of the members is predictive BRCA gene 1 positive. Therefore, yes, we are going to do the hereditary cancer panel testing, which will help in screening the other family members and looking for their risks of getting cancers. A newborn with atypical genitalia, what investigations will you order? We had some very beautiful and simplified flow charts today. I hope you have all noted those. And what investigations will we do for an atypical genitalia? All of these. We need to know the karyotype, we need to know the electrolytes, the blood sugar, 17 OHP. So yes, the answer is very easy and obvious. It's all of the above. Which of the following tests cannot diagnose sex chromosomes? So this one was also pretty obvious. Karyotype, FISH, CMA, SRY, PCR can diagnose sex chromosome, but serum testosterone cannot distinguish a male and a female. So it cannot diagnose sex chromosomes. So this is the end of our MCQs, and there are a few questions. Question 16. Okay, so the answer to question 16, Dr. Monica, is to start LMW and aspirin immediately. Dr. Ruchita Jhawar, could you please write to ICOG and they will get back to you if your answer has been accepted? Okay, Dr. Sharmila, I think today also you could not submit it. So please write to ICOG, and I'm sure Gauri and Nilima madam, you are noting these complaints where a few doctors have not been able to submit the response even today.
Yeah, please take note of that.
Question
Sharmila
7, so Shipra Gupta has asked.
Yeah, it's embryo biopsy. Somebody is asking. Yeah.
No.
Dhanalakshmi is also asked 7 answer. Question 7.
The answer to question 7 is embryo biopsy. Which method is used to obtain cells from an embryo for PGT? It is not amniocentesis, not CVS, not a blood test. It is an embryo biopsy. So a lot of you are asking about the certificate. By next week, please write to ICOG if you have not yet received them. But all of you who have attended all the 3 days, solved all the questions, will receive a certificate and your results. And for any further queries, please write to the ICOG and you will be replied.
You have to have more than 50% pass on of combining all the 3 days. No, combining all 3 days.
Ma'am, each day individually, as is mentioned on the, they have made it more strict. You.
Sita ma'am is being
I'm trying to
lenient
make it more
because
strict.
so many people attended.
Yeah.
So she is just feeling to be generous.
Oh,
Because
let's
the first
accept
day
it.
was
किसी
difficult.
दिन हम उस साइड में होएंगे तो अच्छा है ना कर्मा.
एकदम.
So could we have a formal vote of thanks from Sita ma'am and Chinmay
Yeah.
ma'am? Thank you, Aarti, for a wonderful coordination. Thank you, all speakers,
ma'am.
all attendees. Yes, you all want to know about the next course in advance, and it will be put up on the ICOG website. And you can be in touch with all of us also who could guide you for the
Anytime you
next.
can call us, message us, mail us, or individually or to ICOG. But a big thank you to our president, Dr. Sunita Tandulwadkar, for giving us this vision and opportunity. And of course, Dr. Parag Beniwale, the ICOG chair, for always being so supportive and so encouraging for all that we do and giving us a free hand. Thank you to our Secretary General, Dr. Suvarna Khadilkar, the ICOG Secretary, Dr. Sarita, whom I said earlier, I'm here in another CME. So there's a disturbance here. But thank you to Dr. Sarita, who has been very encouraging and to all the office bearers, to my co-conveners, Dr. Chinmay, Dr. Pooja, who has been so relentlessly chasing all the questions, and the young coordinators, Dr. Aarti, Dr. Navya, and Dr. Kanan. Thank you so much, and big thanks to the ICOG team for putting up all these questions and answers. And to all the delegates who enthusiastically participated and learned a lot, as we all have done too in the last 3 days. Thank you so much. And of course, all the faculties who have taken part, I must not forget them. I'm not naming each one of them, but thank you so much to leave because
I think it was really wonderful 3 days, and we have to thank this platform from Foxy and ICOG, the president of Foxy, Dr. Sunita, and chairperson of ICOG, Dr. Parag. I mean, really putting together a team to make any program. It's the first step, but after that, the team kind of syncing together and doing everything. I did not feel the stress of this program even one day. Maybe I didn't do that much, perhaps. But I thought it was good. We were like kind of working in sync with each other, and I enjoyed it. I enjoyed it thoroughly. So thank you, Dr. Sita, and thank you, Pooja. It's always a pleasure to, work at a level where, it's like a relay race and it just goes on one after the other. So honestly, I'm feeling sad.
Yeah, true. Actually, I was looking forward to this for a long time.
Because that
Because
3:30
all the
getting on
faculty
and
and
logging in and listening to these lectures, and they were wonderful lectures. Actually, we enjoyed each day. We
big
enjoyed.
thanks to this faculty because they all accepted immediately, promptly to speak and deliver despite their busy schedule. So I'm saying bye-bye.
Chalo. Thank you so much. Thank you, Aarti. Bye, Pooja. Bye. Anything you want to say, Pooja? अम्मा पूजा को भी अनम्यूट करना पड़ेगा.
Yes, ma'am.
No, it was real fun. मुझे अच्छा नहीं लग रहा खत्म हो गए.
I know it's like exams, you are so worried till they happen, and then suddenly you feel an empty nest, like what to do
अब
now.
क्या करें? No, it was fun. Chalo, so it was one successful program. Thank you, everyone.